Good morning, everyone. Welcome to the whole day. Now we start the first session, COPS Award Pediatrics. I invite to judge Dr. Manoj Kumar. He is an associate professor. Please start the first lecture.
Go ahead.
First speaker is Dr. H. Santosh Kumar Hilugeri.
Good day to everyone, respected judges and teachers. I am Dr. Santosh Kumar. Title for my study is a randomized controlled trial to compare the occurrence of postoperative nausea and vomiting in early versus conventional feeding in children undergoing day-care surgery under general anesthesia. The time at which the pediatric patients should resume their oral intake after the surgery is ill-defined. The common perception is that early feeding after the surgery increase incidence of postoperative nausea and vomiting. There is no specific evidence that suggests a blanket practice of postoperative fasting of 4 to 6 hours has any benefit. Using the air instead of nitrous oxide and increased utilization of the regional anesthesia techniques have led to reduction in the use of opioids, which has helped in reducing the incidence of PONV. Thus, we should now be able to feed the patients earlier than ever before in the postoperative period. As there is very limited published data on comparison of early versus conventional postoperative feeding in children, we have planned this study with the primary objective of studying the occurrence of PONV with early oral feeding as compared to conventional feeding in children scheduled for daycare surgery under general anesthesia. The secondary objectives of the study were to compare need for antiemetics, degree of postoperative pain and need of analgesics, postoperative complications, duration of hospital stay, and parental satisfaction between both the groups. My study was a randomized controlled trial conducted after approval by the Institutional Ethical Committee, which was registered in Clinical Trials Registry of India. All children of either sex, aged 3 to 10 years, belonging to ASA grade 1 and 2, scheduled for daycare surgery under general anesthesia, were included in the study. And patients with history of motion sickness, gastrointestinal disorders, difficult airway, known allergy to drugs used, and any contraindication to caudal epidural anesthesia were excluded from the study. Informed consent was obtained from the parents, and all the patients were preoperatively fasted as per the standard guidelines. In the operating room, randomization was done to either group of early feeding or conventional feeding using a computer-generated random number sequence, which was delivered in sealed opaque envelopes. Standardized general anesthesia was induced and a weight-appropriate supracortic device was inserted and single-shot caudal epidural was given. At the end of the surgery, general anesthesia was terminated and supracortic device was removed. Patients in early feeding group received carbohydrate-containing oral fluid as soon as the child was fully awake and demanded feed. Patients in conventional feeding group received oral fluid after 4 hours of surgery. Maximum volume of feed given was 10 ml per kg body weight in either group. In the postoperative period after feeding, following were observed and recorded. incidence of PO&V, time, type and volume of first feed given, dose of antiemetics administered, postoperative pain after the first feed using flag score, dose of analgesics administered, duration of hospital stay, complications related to feeding, and parental satisfaction on 5-point scale. Sample size was calculated based on the prevalence of PO&V in a study by Chowan et al. Assuming 80% of power and 95% of confidence interval with 5% dropout rate, the sample size required was 150 patients per arm. Data was compiled and subjected to appropriate statistical analysis. A p-value of less than 0.05 was considered significant. My results: the two groups were comparable with respect to demographic profile. As you can see from the graph, the incidence of PO&V was lesser in early feeding group as compared to conventional feeding group. However, the difference was not statistically significant. The two groups were also comparable in terms of episodes of PO&V, vomiting score, and dose of antiemetics required. Volume of feed administered and type of feed given to both the groups were comparable. However, time to first feed after the surgery was significantly shorter in early feeding group as compared to conventional feeding group. Flag scores were observed between both the groups after the first feed at an interval of 30 minutes for the first 2 hours and then hourly for the next 3 hours. Early feeding group had significantly lower flag scores in the first hour as compared to patients in conventional feeding group. The two groups were comparable with respect to dose of analgesics required and time to first analgesic administered. Patients in early feeding group had significantly shorter duration of hospital stay as compared to patients in conventional feeding group. Parents of the children in early feeding group had significantly much better parental satisfaction score as compared to parents of the children in conventional feeding group. There are many guidelines related to preoperative feeding in children. However, should resume their oral intake after the surgery is still ill-defined and is usually based on the experience of the attending clinician rather than on any sound scientific investigation. In my study, early postoperative oral intake in a conscious child on demand did not increase the incidence of postoperative nausea and vomiting. Study conducted by Cheng et al. Showed gastric motility returns to normal 1 hour after emergence from general anesthesia in children undergoing non-abdominal surgery, making it suitable to feed them early. Study by Radke et al. Had an incidence of PO&V similar to our study. Study conducted by other authors such as Chauvin and Norton et al., who assessed effect of early postoperative liberal oral fluid intake on PO&V, had an incidence of PO&V similar to our study. Shernin et al. In their study had an incidence of PO&V much higher as compared to our study, which was probably due to the fact that the children were supposed to drink, which might have triggered vomiting in them. Study by Wu et al. Had an PO&V incidence much less than our study, which was probably due to low volume of fluid administered to the patients. It is commonly assumed that crying in a child after the surgery is due to pain, which leads to increase and unnecessary administration of analgesics. However, the commonest cause of crying in a child is due to hunger and thirst. Our study is probably the first to evaluate the effect of early feeding on flag score, which showed lower flag scores in early feeding group. Also, patients in early feeding group had significantly shorter duration of hospital stay and much happier parents, which has not been reported earlier in any other studies. Limitation of our study design was with the issue of blinding. The intervention could not readily be blinded. To conclude, early postoperative feeding in children between 3 to 10 years of age scheduled for day care surgery under general anesthesia does not increase the incidence of PO&V as compared to conventional feeding regime and is associated with better pain scores, shorter duration of hospital stay, and improved parental satisfaction. Thus, we highly recommend early feeding in pediatric patients after surgery. These are all my references. Thank you.
Thank you, Dr. Manoj.
Thank you.
Now I would like to invite Dr. Priyanka Singh to start the lecture. Dr. Priyanka.
Morning, everyone.
Yeah, please start.
My topic of presentation is cuffed versus uncuffed endotracheal tube in infants undergoing elective surgery in prone position, seeing peritubal leak at standardized ventilator settings. Principal author is me, Dr. Priyanka Singh, and my co-author and PG guide is Dr. Vinita Singh. Introduction. The basic function of tracheal tube is to provide a reliable connection between the patient's lung and the bag or ventilator. And ideally, this connection should be leak-proof without causing undue pressure to laryngeal or tracheal structures. With an uncuffed tube, the major disadvantage is air ineffectively ventilating the patient with lung disease, environmental contamination of anesthetic gases, risk of aspiration, etc. Endotracheal tube displacement is one of the commonest complications in prone position of pediatric patients. Microcuff endotracheal tube is specifically designed for the pediatric airway anatomy. Some studies report suggest that with low cuff pressure, less than 15 centimeter water, cuff tube can effectively seal the airway without increasing the complication. Our primary objective was to see the incidence of peritubal leak, and secondary objective was to see the incidence of accidental extubation and post-extubation complications. We did the study in Department of Anesthesiology, King's George Medical University, Lucknow. The study duration was 1 year. Design was prospective randomized clinical trial, and sample size was 30 cases in each group. After taking ethical committee. Sample size was calculated on the basis of variation in leakage quantity in two groups using the following formula, where we took type 1 error at 0.05, type 2 error 20%, power study 80%, and considering data loss 10%, so minimum sample size required was n equal to 30 in each group. Methodology. Subjects were randomly divided into two groups using computer-generated random number table. In group 1, patients were intubated with predetermined size uncuffed endotracheal tube, and in group 2, patients were determined size cuffed endotracheal tube. The tracheal tube size was judged as adequate if the leak pressure was 20 centimeter water or less, and the tube was extended to next larger size if the leak pressure was too high, and tube size was extended to next smaller size when cuff pressure exceeded 20 centimeter water. So we included patients or guardian giving consent, age less than 1 year, ASA grade 1, 2, and 3, infants planned for elective surgery in prone position, and we excluded the patients not giving consents, children with airway anomaly, airway pathology, patient at risk of respiratory complications, laparoscopic surgery, and emergency surgery. We study 60 patients with mean age of 5.28 plus minus 2.92 months in our sample population. Male dominance was observed, which was 58.3%. Leak was present in around 56.67% of group 2 patients, while there was no leak in group 1 patients. The p-value came out less than 0.001, which is statistically significant. In group 2 patients, 17 patients were required a change in larger size of uncuffed tube. Patient complication, no statistically significant difference were found. This is the graph. This is the table showing the comparison of peritubal leak, where p-value is less than 0.001, which is significant. This is the bar diagram. This is the table showing comparison of tube exchange rate, which also came out very significant, which is less than 0.001, and in group 2 patients, around 17 patients were required to change in tube to next larger size. This is another table showing group comparison of complications, where p-value shows that there is no statistically significance. In this study, we found that in microcuff pediatric endotracheal tube, less peritubal leak. There is less peritubal leak. This result is supported by Chambers et al. In 2017. They compared the tidal volume and leakage around cuffed and uncuffed tracheal tube in children who required standardized mechanical ventilation of their lungs in operating theatre. According to their research, significant difference, which was p less than 0.001, was observed. In Saifemni et al. In 2016, they found out that the use of cuffed endotracheal tube did not significantly increase the incidence of post-extubation stridor, and tube exchange rate was also low. In the research, they found out the p-value of 0.36 and 0.00001, which respectively. What limitation in future scope? In future, studies should extend this model of research to a larger group of population, and higher age group range can be taken in future. We concluded that in microcuff pediatric endotracheal tube, there is less peritubal leak, and also there is less rate of tube exchange, and no significant difference in postoperative morbidity is found. Hence, this can be safely used in infants. These are my references. Thank you.
Now I like to invite Prabhavati Srinivasan.
Good morning to all my professors and senior faculties. My presentation is about a prospective randomized double-blinded study to compare the analgesic efficacy of ultrasound-guided bilateral suprazygomatic maxillary nerve block with 0.25% bupivacaine and 0.25% bupivacaine with dexmedetomidine in children undergoing cleft palate repair. Cleft lip and palate anomalies constitute nearly 1/3 of all congenital craniofacial malformations, with an average worldwide incidence of 1 in 700 births. The estimated birth prevalence in India is between 27 and 33,000 clefts per year. The birth of the child with cleft deformities inflicts heavy emotional trauma on the parent and the child and causes significant costs in terms of rehabilitation, emotional difficulties, and economics. CT surgeries involve dissection of hard and soft palate, leading to sympathetic stimulation, leading to hypertension, tachycardia, and bleeding. Adequate postoperative pain relief, especially 24 to 48 hours, is an important concern for children, as a vigorous strain may result in leading to slow recovery and delay in discharge from the hospital. Local anesthetic infiltration, nerve block, opioid, and NSAIDs are current available modalities for the postoperative analgesia. Excessive use of opioids lead to respiratory depression and airway compromise, whereas use of NSAIDs are associated with increased risk of postoperative bleeding. In general anesthesia provides adequate analgesia with a prolonged duration of action and decreases the need for intraoperative and postoperative supplemental analgesia. Orofacial block like greater or lesser palatine and nasopalatine nerve block have been successfully used either alone or in combination to reduce the postoperative pain. The suprazygomatic maxillary nerve block is a simple and reliable technique for children with fewer complications that provide effective analgesia with a decreased perioperative opioid consumption. Real-time ultrasound guidance allows non-invasive imaging of ptericopalatine fossa and associated with a higher block success rate and reduced complications. Studies have shown that dexmedetomidine, when added to the local anesthetic during nerve block, prolongs the duration of both sensory and motor blocks without any side effects. In our study, we investigated the analgesic efficacy of 1 mg per kg dexmedetomidine and adjuvant with a 0.25% bupivacaine to that of blind bupivacaine in ultrasound-guided SMB block for children undergoing cleft palate repair. Postoperative fentanyl consumption for 2 hours, paracetamol consumption for 24 hours, and postoperative pain score using CHIP scale were taken as the study parameters. Materials and methodology is a prospective randomized double-blinded study conducted for a duration of 3 months in Department of Anesthesiology in Sri Ramachandra Medical College and Research Institute after IAC approval and CTRA registration. The sample size was calculated with the below mentioned formula for a power of 80% and 5% alpha error. The final sample size is 46 and 23 in each group. These were as fixed as the inclusion and exclusion criteria for our study. 46 children with the ASA 1 and 2 physical status inclusion criteria were enrolled in the study. Children were adequately passed prior to the procedure as per the ASA guideline and randomized into Group A and Group B. Group A received 0.25% bupivacaine saline. Group B received 0.25% bupivacaine with 1 mg per kg dexmedetomidine. After pre-medication with oral midazolam, induction was done with 8% sevoflurane and 5 liters of oxygen and IVS is established. Following IV, 2 mg per kg fentanyl and 0.5 mg per kg atracurium was given. Intubation was done with the uncuffed oral dry endotracheal tube. The anesthesia was maintained with 1 to 1.5% of MAC with sevoflurane. Guided bilateral SMB was performed with a high frequency probe placed in the infrazygomatic area over maxilla to locate the ptericopalatine fossa. After identifying internal maxillary pulsation, needle was advanced into the fossa by using outplane approach. After a negative blood aspiration test, identification of the needle tip, 0.15 ml per kg of diluted composition, as slowly injected and the spread of local anesthetic solution within the fossa was visualized by the ultrasound. These are the picture taken while performing block in one of our patients. The surgical incision was initiated after 15 minutes of the block. Intraoperative hemodynamics parameters like heart rate, BP, SpO2, EtCO2 were monitored and documented every 15 minutes until the end of the surgery. At the end of the surgical procedure, children were extubated after adequate reversal and prompt suctioning. Extubation vitals were recorded and patient was shifted to the PACU. On arrival in the PACU, pain was assessed by children and infants post-operative pain scale at 0 minutes and then every 30 minutes up to 2 hours and then every 2 hours till 24 hours in the ward. The pain control was considered insufficient if CHIP score was more than 3, for which injection fentanyl 0.5 mg per kg was administered for the first 2 hours up to the maximum of 2 doses. Afterwards, injection 15 mg per kg paracetamol was administered, maximum 4 doses till 24 hours. Patients who had pain after giving all this rescue analgesic were considered to have a failed block and planned to be excluded from the study. Study groups, both Group A and Group B, were considered as the primary exploratory variables. Age, weight, ASA, gender, systolic and diastolic BP, heart rate were considered as variables. Independent sample t-test, Mann-Whitney U test, paired t-test were used to assess statistical significance. P-value less than 0.05 was considered statistically significant. Both the group in our study were similar with regarding to the age, weight, gender, and duration of surgery. Comparison of CHIP score between two groups. The CHIP score in Group B was significantly lower at 0 minutes, 1 hour 30 minutes, 2nd hour, 4th hour, 6th hour, and 8th hourly, with a significant p-value of less than 0.05. Comparison of fentanyl consumption between groups. None of the patients in the Group B required rescue opioids in the initial 2 hours in the PACU, whereas 6 patients in the Group A required 1 to 2 doses of fentanyl rescue analgesia. Comparison of paracetamol consumption between groups. Majority of the patients in the Group B did not require rescue analgesia in the ward, compared to the only 34% in the Group A. The frequency of rescue analgesia consumed is also less in Group B in comparison to the Group A. No significant differences were noted between the groups with respect to the intraoperative heart rate, systolic and diastolic BP parameters. Discussion: dexmedetomidine, when used as an adjuvant to the 0.5% bupivacaine, reduce the postoperative pain, reduce the need for rescue analgesics, reduce the postoperative fentanyl and paracetamol consumption. It also provided stable hemodynamics throughout the intraoperative period with nil complications. None of the subjects developed any complication in our study. The limitation of study was we did not assess a sedation and agitation score in the postoperative period, a small sample size of the single center study. Conclusion: dexmedetomidine can the regional block to prolong the duration of analgesia with reduced rescue analgesic requirement, thereby providing a better postoperative comfort for the patient and faster recovery. These are my references. Thank you.
Thank you, Dr. Prabhavati.
Thank you, sir.
Now I would like to invite Dr. Rusda Rehman to start the presentation.
One and all, myself Rushda Rahman, presenting before you the effect of general anesthesia and subarachnoid block on neutrophil to lymphocyte ratio in pediatric patients undergoing infraumbilical surgery. The neuroendocrine system is activated during anesthesia. Due to surgical trauma-induced stress causes suppression of cellular resistance and increases susceptibility to inflammation. Several markers such as interleukin-6, TNF-alpha, cortisol has been used to assess the severity of inflammation and immune response, though they are sophisticated but very expensive. Neutrophil lymphocyte ratio has been suggested to be a simple and inexpensive marker for inflammatory response. Anesthetic technique may also modulate the inflammatory response in surgical outcome. The aim of our study to investigate the effects of anesthetic technique on NLR in pediatric age group. Objective was to investigate the effects of general anesthesia and subarachnoid block on neutrophil lymphocyte ratio in pediatric patients undergoing infraumbilical surgery. The methodology includes institutional ethical committee clearance, parental consent were obtained, and a prospective randomized double-blinded study was conducted over a period of 4 months. The sample size was of 42 patients, of which group C included 21 patients given general anesthesia and group S included 21 patients given subarachnoid block. The inclusion criteria included ASA 1 and 2 patients of age group 3 to 12 years of both sexes undergoing infraumbilical surgery for a duration of less than 90 minutes. Exclusion criteria included refusal of the patient's contraindication to spinal anesthesia or history of local anesthetic hypersensitivity, hemodynamically unstable, malignant endocrine, hepatic and renal dysfunction, immunodeficiency, history of chemo or radiotherapy, use of anticoagulants with existing acute infection. Patients undergone pre-anesthetic checkup and on the day of surgery kept nil per orally. On the day of surgery, IV line was secured and monitors were attached after shifting the patient to pre-operative room. Blood sample for complete hemogram was collected. Injection dexmedetomidine 1 mics per kg. Loading over 10 minutes in pre-operative room under monitoring was given till the Ramsay score, sedation score of 2 was attained. Patient shifted to the OT where IV injection fentanyl 1 mics per kg was given. Hemodynamic parameters were monitored as per the institutional protocol till the end of the surgery in both the groups. Procedure for group G include pre-oxygenation with 100% oxygen for 3 minutes, induction propofol 2 mg per kg and relax with injection atracurium 0.5 mg per kg. Airway secured with appropriate size of second generation supraglottic device. Maintenance with oxygen, nitrous oxide, atracurium and propofol infusion. At the end of surgery, muscle relaxation reversed with standard dose of neostigmine and glycopyrrolate. Procedure for group S included lumbar puncture done in lateral decubitus position in L3, L4, include using 26 gauge needle. Injection bupivacaine heavy of dose 0.3 mg per kg injected in CSF over a period of 15 to 30 seconds. Effect were assessed. Post-operative blood sample was sent for NLR at a period of 6 hours and 24 hours. Demographic profile suggests a mean age of our patient was 8, male 28, female 14, mean weight was 14.33 kg and mean duration 90 minutes. The sample size of 42 patients were taken. There was no dropouts. Demographic characteristic was and duration and type of surgery was comparable in both the groups. At T0 in group S and group G, the value was comparable. That is, p-value was less than 0.42, whereas T6 there was significant difference in both the groups and the p-value was less than 0.014, and again at T24 the value was comparable. The data analysis was done using SPSS 25.0. The independent t-test was used to compare the ratio. The following graphs shows at T0 and T24, the value was comparable, where at T6, it was a significant difference in both the groups. In our study, it was observed that subarachnoid block is associated with lower NLR compared to general anesthesia. The difference was significant at 6-hour post-operative interval. Studies were depicted to show that changes in TLC and NLR is associated with increase in morbidity and mortality, as increase in TLC and decrease in leukocyte in post-op period may infection. Study conducted by Netra Sanhan, which compared the effect of anesthetic technique on NLR in adult patients undergoing infraumbilical surgery, found that general anesthesia was associated with a greater increase in TLC and NLR as compared to spinal anesthesia. Similar study done by Mesut Ilbas et al. On patient undergoing cesarean section and found post-op NLR was lower in subarachnoid block than general anesthesia. But a study conducted by Bukosak et al. Assessing the effects of general and spinal anesthesia to hemorrhoidectomy found no significant. No study has been done in children, to our knowledge, to evaluate the influence of anesthetic technique on NLR. Different types of anesthesia might have indirect effect on post-operative complications by influencing NLR. Hence, an appropriate choice of anesthesia could influence the outcome. There are certain limitations associated with our study. Firstly, the patients were not allowed to follow up beyond 24 for other infection. The relationship between NLR and the incidence of post-operative infection and post-operative outcomes could not be. No other inflammatory markers were assessed in order to establish a correlation between anesthetic technique and inflammatory response. I conclude that the demographic parameters were comparable between the groups, and NLR was significantly lower in group S than in group G. That is, spinal anesthesia has less inflammatory response than comparison to group general anesthesia. Thank you.
Thank you, Dr. Rusda. Now I would like to invite Dr. Ketki Khasnis.
Topic is comparison of age-based versus the length-based method using closed flow tape for estimating endotracheal tube size in Indian children. Intubation may be required in pediatric patients in either elective or emergency cases. Selection of a proper size ET tube is the key to a successful intubation and effective ventilation. An undersized ET would cause a gas leak, loss of tidal volume, and risk of aspiration, and large-sized tube can lead to postoperative complications. Various formulae have been published for the selection of uncuffed ET tube in children, most of which are based on studies in European children. In India, the formula most commonly used is the Penlington's formula, which is age by 3 plus 3.5 is the internal diameter in children less than 6 years, and for children more than 6 years, it is age by 4 plus 4.5. But this formula, being based on studies in European children, cannot be applied to Indian children due to the differences in the nutrition, facial differences, and developmental differences. The study aims at comparing the traditional age-based formula and the length-based method using closed flow tape to estimate the appropriate size ET tube. This 3-month hospital-based observational study was carried out at KLE's Dr. Prabhakar Kore Hospital and Medical Research Center after obtaining clearance from Institutional Ethics Committee and consent of the guardians. ASC grade 1 and 2 patients between 1 to 6 years of age undergoing elective surgeries under general anesthesia were enrolled for the study. Patients with a known difficult airway requiring intubation with tubes other than PVC tube, undergoing emergency surgeries and requiring rapid sequence induction, and patients whose guardians did not give consent for the study were excluded. The total sample size of 60 was calculated using the below formula. Patients underwent a detailed pre-anesthetic evaluation before surgery where age, height, and weight was noted. CBC was done for all the patients. The child was kept NBM for at least 2 hours for clear fluids, 4 hours for breast milk, and solid foods. After confirming the nil by mouth status and consent, the child was given intravenous glycopyrrolate and ketamine and then shifted to OT where standard monitoring devices were attached. Patient was pre-oxygenated with 100% oxygen for 3 minutes, followed by pre-medication with intravenous midazolam and injection ketamine, and induced with injection ketamine. Injection choline was given for skeletal muscle paralysis to facilitate endotracheal intubation, which was done by a senior anesthesiologist with the ET tube size as per their discretion. The ET tube size used was deemed to be of correct fit based on bilateral equal breath sounds, square wave capnograph, ET tube passing through the glottis smoothly, and presence of minimal air leak and expired tidal volume of more than 7 ml per kg with a peak inspiratory pressure of 15 centimeters of water and respiratory rate as per the child's age. In case of an unacceptable large leak and delivery of insufficient tidal volume, ET tube was exchanged for a bigger size tube and such a patient was excluded from the study. Size of the ET tube put was then correlated with the 2 study methods. For the analysis, mean and standard deviation were calculated, and for all the tests, the p-value of less than 5% was considered significant. The study conducted in 60 patients, data was collated using Microsoft Excel, students' unpaired t-test and SPSS software. The minimum age of the population was 1 year and maximum was 6 years with a mean age of 2.6. In our study, there were 47 male patients and 18 female patients with a mean height of 86.6 centimeters. In the study, each method was tested for a clinically accepted ET tube size by subtracting the size predicted by each method from the actually used tube. A difference of 0 indicated that the method gave the tube size closest to the actually used ET tube. Here in this example, the actually put ET tube was 5.5 and as per the length also it was 5.5. Difference is 0, so the length gave the accurate estimate. If the difference between the two was a negative number, then the predictive method selected a tube larger than the actual size. And if the difference is a positive number, it indicates that the method estimated a smaller size tube. Here, the actually put ET tube was 4, and by both the methods, the tube estimated was 4.5. So, both the methods overestimated the size. The above mentioned calculation was done for all 60 patients and their mean was calculated. The mean of difference of the actual put ET tube and the ET tube estimated by the age-based formula is minus 0.2, while that estimated by the length of the child is minus 0.1. As per the analysis, the least mean difference is for the ET tube size as per the length of the child. P-value for the length-based method is 0.004, while that for the age-based is 0.08. Thus, to conclude, among the two methods in the study, length-based is more accurate. Endotracheal intubation is the gold standard method for securing airway in children in emergency or elective surgeries. It is of importance that a correct size ET tube is used to prevent any perioperative complications. Various formula, including the use of height, weight, age, size of fingernail, radiograph of the neck, and more recently the subglottic diameter of the airway have been described. An ideal method is the one which is easy to use and has a high accuracy. In the present study, we compared the conventional age-based method and the length-based method using gross flow tape. Age-based method is being used by anesthesiologists all over the world as it is convenient and easy to use. The gross flow tape is a 8 color-coded length-based tape that relates the height of the child to his or her weight to provide instructions for drug dosages as well as the size of equipment. The mean of the actual put ET tube in our study was 4.66 with a deviation of 0.6 mm, which was comparable to the size estimated by the length of the child, which had a mean of 4.6 plus or minus 0.57 mm, while the age-based method had a mean of 4.55 with a deviation of 0.63 mm. Our results were comparable to a study by R.C. Luton, in whose study the length-based estimation was correct in 77% of the cases. A study conducted by M. Ganesh Kumar and authors found that the length of the child is a better predictor of uncuffed ET tube. They developed a formula saying that internal diameter is 3 times the length of the child in meters plus 2.5. Ming Wu, Shi, and others compared the efficacy of a length-based formula with the standard age-based formula and concluded that the length-based formula has a high accuracy. Limitations to the present study: we used only PVC tubes, so validation of the method and estimating the size of other tubes like RAE or flexometallic cannot be ascertained. Age group of the study was 1 to 6 years, where uncuffed ET tubes are used predominantly. So findings of this study may not hold true for cuffed ET tubes. Similar studies can be undertaken in the future for other types of tubes. So thus, to conclude, the length of the child has a good correlation to the size of ET tube to be used, especially in Indian children. Gross flow tape is an effective tool to predict the ET tube size, especially where age and weight are unknown, like in trauma cases or unconscious child. These are my references. Thank you.
Thank you. Now I like to invite Neha Adhyapak, please. Neha Adhyapak.
Hello, everybody. I, Dr. Neha Sanjeev Adhyapak, would like to present a study titled The Effect of Preoperative Gastric Ultrasound Examination on the Choice of General Anesthetic Induction Technique in Pediatric Patients Posted for Surgery, under the guidance of Dr. Rajesh Mani, sir. In modern anesthesia practice, the incidence of pulmonary aspiration is low since the quality of anesthesia care being provided is of high cadre. However, it hinders accurate identification and measurement of factors that increase the risk of complications, which requires attempts to further improve the quality of anesthesia care that are based on anecdotal experiences rather than controlled observations. Although the risk of aspiration majorly occurs at induction of anesthesia, tracheal extubation and recovery are also at a risk. Ultrasound examination of the gastric antrum is a non-invasive, easy to perform, reliable tool that helps in the assessment of the gastric contents in both adults and children. The primary objective of the study was ultrasonographic assessment of gastric volume to determine the most appropriate induction technique. And the secondary objective was to assess the gastric volume and content by aspiration of the nasogastric tube. After obtaining ethical clearance and parents' consent, the children aged between 6 months to 16 years posted for elective or emergency surgeries under ASA grade 1 and patients who did not give consent, ASA grade 3 and 4, anticipated, unanticipated difficult airway, patients who had contraindications to insertion of nasogastric tube, and in whom USG was inconclusive were excluded from the study. Ultrasound was performed in the 45% semi-recumbent position and then right lateral decubitus position. And then the assessment was done according to the Perlas grading. That is, grade 0 is absence of any content in both positions. Grade 1 was clear fluid in the right lateral decubitus position only. Grade 2 was clear fluid in both positions or presence of thick fluid. After the USG was performed, the choice of induction was decided, either routine or rapid sequence. After induction of anesthesia, the tracheal intubation, a Ryle's tube was inserted. Gastric contents were then suctioned into a 10 ml syringe. The volume of gastric contents were recorded. The stomach contents from the gastric tube suction were defined as above risk and below risk. Above risk is when the clear fluid was more than 0.8 ml per kg or there was presence of any thick fluid. Otherwise, it was below risk. Here are 3 images showing gastric antrum in semi-recumbent position with content. Here, there is no content. And here you can see the collapsed antrum in right lateral position. The statistical analysis was done. Sample size was calculated according to the following formula, with which we got a sample size of 84. The association between the outcome, the clinical and demographic data characteristics were tested using mainly chi-square and ANOVA and other parametric and non-parametric tests. For all the tests, the value of P less than 5%, that is 0.05, is considered significant. Here are the results showing the demographic data where the distribution of male and female was almost equal. At 42% were female and 58% were male. The mean age was 7 years. Weight was 19.3 kgs. You can see here the association between the Perlas grade and the choice of induction technique, where if the p-value shows is 0.002, that is highly significant. Also, the association between the Perlas grade and nasogastric tube content shows high significance. The same is being represented graphically. Also, the association between the Perlas grade and nasogastric volume shows high significance. Coming to the discussion, in this study, we observed that out of 84 patients examined, RSI was performed in, that is rapid sequence, was performed in 39 of them after ultrasonographic assessment. P-value was highly significant for appropriate technique of induction based on Perlas grade. Confirmation of gastric volume by nasogastric tube aspiration was also highly significant. When a similar study was conducted by Gay et al., where they conclude more than 85% of the children had an appropriate induction technique was performed. Also, in another study conducted by Bouvet, less than 1% elective children had potentially increased risk for pulmonary aspiration. From the study, we can conclude that ultrasonography is a useful guide to assess the gastric volume for the choice of general anesthetic technique that can reduce the risk of pulmonary aspiration in both elective and emergency surgeries. Here are the references that were followed through. Thank you.
Now I like to, thank you, doctor. Now I like to invite Dr. Neha Vani Vasudev.
Hello everyone, I'm Dr. Vani Vasudevan. My topic is the effects of volume control and pressure control volume guaranteed modes of ventilation on respiratory dynamics during laparoscopic surgery in children, a prospective observational study. The use of pediatric laparoscopy has increased significantly. The respiratory changes during laparoscopy are mainly due to 3 factors. Raised IAP in pneumoproton, which will lead to a cephalic shift to diaphragm, decrease in FRC compliance, and increase in resistance. Carbon dioxide absorption, which will lead to an extra load in the respiratory system, hypercardiorespiratory residues, and rarely air embolism. Positioning, which can worsen the effects of pneumoproton, especially to Trendelenburg position, with a decrease in FRC and increase in resistance. Volume control mode of ventilation, where the ventilator delivers a preset tidal volume with a constant flow during the preset inspiratory rate and the preset respiratory rate. This can lead to generation of high peak pressures. The pressure control mode of ventilation, where the ventilator delivers the preset pressure during the preset inspiratory time with the preset respiratory rate. The lower peak pressure is required to deliver the same tidal volume with a decelerating flow pattern. Pressure control volume guaranteed mode of ventilation is the newer mode which delivers the preset tidal volume with the lowest possible pressure with a decelerating flow during a preset inspiratory time and respiratory rate. The ventilator delivers the first breath is volume controlled breath. The compliance is determined and then the inspirated pressure level is established with subsequent breath. As VCV is the most commonly used mode of ventilation and PCVVG is a new mode, the project is designed to study the effects of VCV and PCVVG modes of ventilation on respiratory dynamics during laparoscopic surgery in children. Very few studies have been done on the effects of PCV-VG on respiratory dynamics during lap surgery in children. Therefore, we plan to do the study. The existing literature is mostly on the effects of only VCV and PCV modes of ventilation. Aim to study the effects of volume control and pressure control volume guaranteed modes of ventilation on respiratory dynamics during laparoscopic surgery in children. Objective to compare the following parameters in VCV and PCV-VG modes of ventilation at baseline following abdominal insufflation and the change of position. The peak inspirated pressure, plateau pressure, compliance, airway resistance, EDCO2 and oxygen saturation. It was a prospective observation study conducted in operation theaters at Tertiary Care Center from November 2018 to August 2020 after approval from the Institutional Ethics Committee and CTRI. The study population comprised of 52 patients aged from neonates to 15 years and the sampling method was constitutive convenient concerning sampling. Inclusion criteria included the patients scheduled for elective laparoscopic surgeries under GA, both genders, patients aged from neonates to 15 years, ASA class 1 and 2, and parents giving valid informed consent. And the exclusion criteria included obesity and children with active cardiopulmonary disease. Written valid informed consent from the respective parent or guardian was obtained. GA was given as per the routine OT protocol. The ventilator was set on either VCV or PCV-VG mode. Tidal volume of 6 to 10 ml per kg and age appropriate respiratory rate was set to maintain a normal EDCO between 30 by 40 millimeters of mercury. In both the modes, the pressure limit was set at about 10 centimeters above the initial peak pressure achieved. After pneumoperitoneum or change of position, if required, the respiratory rate and the tidal volume were adjusted to maintain a normal EDCO. The set parameters include tidal volume, respiratory rate, IE ratio, PEEP, pressure limit, and FiO2. And the measured parameters included the peak inspirated pressure, plateau pressure, mode of ventilation, compliance, airway resistance, EDCO2, and saturation of oxygen. The parameters were noted at the following points of time. 5 minutes after intubation, after creation of pneumoperitoneum, after changing the position, after abdominal desufflation, and after the change of position to normal. For sample size derivation, the reference was a study conducted by Kothari and Bakr on the comparison of respiratory dynamics during lap polycystic in adults with BCV and PCV-VG. The dynamic compliance noted post-intubation were 33.8 for plus or minus 6.56 and 45.32 plus or minus 7.15. Alpha error 0.05, beta error 0.2. The software used was Power and Sample Size Calculator version 3.0.43. Number was derived as 10 in each group and it was decided to take 20 in each group. For statistical analysis, SPSS version 16 was used. Quantitative continuous data, if normally distributed, were noted as mean plus or minus standard deviation and analyzed using unpaired t-test. If not normally distributed, it was noted as median and analyzed using man-using t-test. Intergroup comparison of percentage change in parameters was done using unpaired t-test. A total of 84 lab surgeries were done in the duration of the study. 15 were excluded as the patients were ASA3 or not giving consent, and 69 were included, of which 17 were removed as the procedure got converted to open or due to the unavailability of performer. Finally, 52 patients were included with 26 in each group. The demographic variables were comparable in both the groups. The distribution of males and females were also similar in both the groups. The distribution of patients according to the position given during the surgery showed that Trendelenburg position were given for the maximum number of patients, that is 46.2%, with 11 patients in VCV group and 13 patients in PCV-VG group. The comparison of certain observed respiratory parameters in the two groups after intubation showed no significant difference, and the comparison of certain observed parameters after abdominal insufflation also showed no significant difference between the two. The comparison of percentage change in the certain observed parameters between T1 and T2 also showed no significant difference. As maximum number of patients were given Trendelenburg position during the surgery, the parameters were compared and analyzed only in these patients. The comparison of certain observed parameters between the two groups after Trendelenburg position showed no significant difference. But the comparison of percentage change in the set parameters between T1 and T3 showed that the respiratory rate had significantly increased in VCV group when compared to the PCV-VG group in order to maintain normal EDCO2. But the difference in percentage change, there was no difference in percentage change in observed parameters between the two groups. The comparison of certain observed parameters within the two groups after abdominal desufflation and normal position showed no significant difference. Hemodynamic data was similar without any significant difference in the two groups at all points of time. The peak inspirated pressure and the plateau pressure increased after abdominal insufflation and Trendelenburg position in both the groups, and compliance decreased and resistance increased in both the groups after abdominal insufflation and Trendelenburg position. In a study conducted by Diane et al. In 2014, the PCV-VG and PCV resulted in a lower peak inspirated pressure, and Asa et al. In 2016 found that the PCV-VG group had a significantly lower peak inspirated pressure and higher dynamic compliance. Kothari and Bhaskar in 2018 found that the peak pressure was lower in PCV-VG and PCV group. Kim et al. In 2018 found that the mean pressure was significantly lower in PCV-VG group. Toker et al. In 2019 found that the PCV-VG group had significantly lower peak peak inspirator pressure, mean pressure, plateau pressure, and higher dynamic compliance and BCV. Gad et al. In 2019 found that the peak pressure was significantly higher in BCV and dynamic compliance was significantly lower in BCV group. Jungmindy et al. In 2020 found that the peak pressure was higher in BCV and dynamic compliance was lower in BCV group. Liu et al. Conducted a prospective randomized control trial on the effects of PCV-VG on respiratory dynamics in pediatric laparoscopic surgery. They concluded that PCV-VG provides a lower peak pressure and better dynamic compliance when compared to VCV during laparoscopic surgery. But when we started the project, no such studies were available in the pediatric age group. The problem reasons why there was no significant benefit in children with PCV-VG might be tissues are highly compliant and distensible, and children with healthy lungs without any comorbidities were considered. Strength of the study, newer modes of ventilation have become available with newer machines. And to the best of our knowledge, very few studies are available comparing the effects of PCV-VG and VCV modes of ventilation on respiratory parameters during lap surgery in the pediatric age group. Considering these factors, we decided to cover these limitations in our study. Limitations of our particular study, it was an observational study and not a randomized one, with a small sample size and wide age range, and subgroup of patients given Trendelenburg position was considered for the reduced sample size. Factor of IUP was not considered. The study was conducted on pediatric patients posted for any laparoscopic surgery and not a specific laparoscopic surgery. Concluding, either PCV or PCV-VG mode of ventilation can be used during pediatric laparoscopic surgery in supine position. However, with Trendelenburg position, PCV-VG provides a marginal advantage over VCV mode of ventilation. These are my references. Thank you and have a nice day.
Now I like to invite Dr. Srihari Jitoru, please.
Myself, Dr. Jitoru Srihari, postgraduate in Department of Anesthesiology, BMCRL, Bengaluru. I would like to present study of effect of dexmedetomidine nebulization on parental separation in pediatric patients. My guide, Dr. Tulsi T. The importance of the study is preoperative anxiety is seen in 50 to 70% of the children posted for surgery. Children with high preoperative anxiety have high incidence of intra-op adverse events like tachycardia, hypertension, postoperative pain, emergence delirium, delayed discharge, and maladaptive and behavioral changes that can last for weeks in the postoperative period. That is painful for both children and the parents. Inhalation of nebulized drug is an easy alternative for preoperative sedation in children as it avoids needle puncture necessary for IV or IM injections to give sedatives. The aim of the study is to effect of nebulized dexmedetomidine on parental separation in pediatric patients. Study was double-blinded randomized control study with 2 groups of 46 each patients over a period of 3 months in a tertiary care hospital. Children in the age group of 1 to 10 years with ASA grade 1 and posted for elective surgery were included in the study. Children allergic to dexmedetomidine on patients with a history of congenital heart disease, on patients with heart rate less than 70 beats per minute, patients who refuse to give informed consent, patients with asthma were excluded from the study. After obtaining informed and written consent, routine preoperative workup was done. Preoperative vitals parameters were recorded. Study participants were divided into 2 groups of 46 each. Group D received dexmedetomidine nebulization at 2 miles per kg body weight, diluted to 3 ml ms, given over a period of 15 minutes. And Group C received normal saline nebulization 3 ml. Patients were given nebulization preoperatively for a period of 15 minutes, and parental separation anxiety scale was noted 5 minutes before shifting to operating room. Patients were monitored intraoperatively and 1 hour post-operatively. The study scale used was parental separation anxiety scale, where grade 1 was easy separation of children from the parents, grade 2 where child whimpers but is easily reassured, not clinging to parents, grade 3 cries and cannot be easily reassured but not clinging to parents, grade 4 crying and clinging to parents. The results were in Group D, 29 children out of 46 had parental separation anxiety scale of 1 and 2, whereas 15 in Group C. The study was statistically significant. P-value was 0.02. Nebulized dexmedetomidine is well observed systematically via nasal and buccal routes, and the pharmacological effects are similar after IV administration. It acts as both sedative and also analgesic. Patients who had received dexmedetomidine nebulization had better parental separation than those normal saline nebulization. Dexmedetomidine also reduces analgesic requirement intraoperatively and postoperatively. Prio et al. Studied the effect of intranasal dexmedetomidine at 2.5 mg per kg body weight in children aged between 2 to 6 years. The study showed satisfactory separation from parents in 80% of the patients. Zanetti and Elmetini found that there is no incidence of bradycardia or hypotension with 2 mg per kg body weight of nebulized dexmedetomidine. And this was the basis to take the dexmedetomidine at 2 mg per kg body weight for our study. Coming to conclusion, we can conclude that nebulized dexmedetomidine at a dose of 2 mg per kg body weight provides better parental separation in pediatric patients, as children in group D were having parental separation anxiety scale of 1 and 2 or more when compared to group C. Also, nebulization would be a better alternative instead of IV or IM access to administer drugs. These are my references. Thank you, everyone.
Thank you, Sri Hari. Now I like to invite Neha Sinha.
The topic of my study is a comparative study to confirm the endotracheal tube placement using ultrasonography and standard auscultation method in children. Introduction. Pediatric population have shorter tracheal lengths as compared to adults. The positioning of the tracheal tube occur in 20 to 50% of the patients, which can cause hypoxemia, atelectasis, hypercarbia, barotrauma, pneumothorax, and even death. Hence, it is important to place the endotracheal tube correctly. Direct visualization of the glottis and passing the tracheal tube under direct vision is considered the gold standard, but is also prone to errors. This is an image comparing the adult airway and pediatric airway. We can clearly see the shape of the adult larynx is cylindrical in shape, whereas that of a pediatric age airway is funnel shaped. Also, pediatric age group have larger tongue, and the epiglottis is floppier and U-shaped. The level of the larynx is at C4, C5 cervical vertebra, whereas in an adult, it is at the level of C6 cervical vertebra. The trachea is more flexible in pediatric age group, whereas the trachea is kind of fixed in adult airway. All of these differences make the pediatric airway a difficult airway and more prone to malpositioning of the endotracheal tube. The methods to confirm the ET tube position commonly used are lung auscultation, chest wall movement, and capnography. Suboptimal positioning is seen in 30% of the cases. When it is detected, it is confirmed with the help of auscultation alone. The other methods are chest radiography, but they pose a radiation hazard. Fiber optic bronchoscopy is an invasive procedure and requires expertise. Upper airway ultrasonography, which gives an indirect dynamic evidence of the ET tube position. It visualizes diaphragmatic and pleural motion, indicating lung expansion. Sonographic sign of normal lung ventilation is the lung sliding sign, which can be seen as a back and forth sliding of the parietal and vistral pleura over each other. This is an image. This shows the pleural line on an ultrasound as a white shiny line, which can be seen in an image, which can be seen in this image. During normal ventilation, this shiny line seems to slide over each other, hence giving it a lung sliding sign. And the aims and objectives of our study was to compare the ultrasound and standard auscultation method in terms of accuracy and rapidity in detecting the ET tube position. The methods used were, after obtaining institutional ethical committee approval, a written informed consent of all the patients were taken. Prospective study was done. 75 pediatric patients between the age group of 2 to 8 years of either sex of ASA physical status 1 and 2 who were scheduled for elective surgery under general anesthesia and requiring endotracheal intubation with cuff tubes were taken. The techniques used was a uniform anesthetic protocol was followed. All patients were pre-oxygenated for 3 minutes and were further induced with injection fentanyl. injection thiopentone sodium, and graded concentration of sevoflurane in 50% oxygen and 50% nitrous oxide. Neuromuscular blockade was done using injection vecuronium. After performing a direct laryngoscopy, intubation was done with cuffed endotracheal tube of appropriate size, which was predetermined by the Heinz formula. The method of examination consisted of 3 anesthetists. The first anesthetist was responsible for the auscultatory confirmation of the tube. The second anesthetist performed the ultrasonography to ascertain the position of the tube within the same areas as auscultation. And the third anesthetist, who was not involved in the study, measured the time taken for auscultation and ultrasonographic confirmation. The obtained results were compared with the positive result of quantitative sonography, which was set as detection of exhaled CO2 of more than 30 millimeter of mercury after at least 5 breaths with a typical CO2 waveform. The outcomes assessed were time taken for confirmation of the tube by using both the methods, the location of the tube by using both the methods, and accuracy of each technique. And the results were obtained by the waveform capnography, which was done in all the patient and was kept as a gold standard. We can see that 10 endobronchial intubations took place, whereas there were 5 esophageal intubations and 60 endotracheal intubations over there. Auscultation could detect 67 tracheal intubations out of 75, 3 bronchial intubations, and 5 esophageal intubations, whereas ultrasound detected 59 tracheal intubations, 5 esophageal intubations, and 11 bronchial intubations, which made this result more closer to the gold standard result. In terms of accuracy and rapidity, the time taken by auscultation was 32.84 seconds, whereas the time taken by ultrasound was 136 seconds, which was significantly higher. But in terms of accuracy, the ultrasound was found to be more accurate with a 90.67 accuracy rate percentage and 74.67 accuracy in case of auscultation. Discussion. A similar study was conducted by Arafa et al., who studied the accuracy and rapidity of bedside upper airway and standard auscultation for confirmation of the ET tube in 107 adult patients. Ultrasound revealed significantly higher sensitivity, specificity, and accuracy as compared to the auscultation. The accuracy was 95.3% in case of an ultrasound, and whereas it was an 88% in case of auscultation. The time required, however, for confirmation was faster in ultrasound. Similar results were observed by Ram Singh et al., who intubated 42 patients and found the sensitivity and specificity of lung sliding to be 93 and 96% respectively. In our study, the accuracy of ultrasound was significantly higher, which could be attributed to the noisy environment and the possibility of referred sounds and misinterpretation with the auscultatory method. The contradictory findings in terms of the time taken by ultrasound was attributed to the clinical experience of the physician. So we concluded that ultrasonography, being a more sensitive and a specific diagnostic tool in detecting the location of the ET tube, is a highly dependent clinical experience of the anesthesiologist. So we suggest a regular use of ultrasonography as an essential theater equipment for accurate confirmation of the endotracheal tube location, especially in pediatric airway management. Thank you.
Thank you. Now I like to invite Karishma Dalwani. Discuss.
Good morning, sir. Good evening. I'm Dr. Karishma Dalwani from Sri Aurobindo Institute of Medical Sciences. Now my topic for paper presentation is comparison of oral chlorine and oral midazolam as pre-medication for pediatric surgery in children. Children undergoing surgical procedures can experience significant anxiety and distress during perioperative. Use of sedative pre-medication will help to reduce anxiety, minimize the emotional trauma, and facilitates more induction of anesthesia. Midazolam is very common use. Clonidine is a central sympatholytic that provides sedation, anxiolysis, and analgesic effect without causing respiratory depression. Hence, we have made an effort to compare oral chlorine or midazolam for pre-medication pediatric surgery. Material. The study was undertaken in Department of Anesthesia and Critical Care, Sri Aurobindo Institute of Medical Sciences. 60 patients of pediatric patients were scheduled to undergo surgery. Pediatric patient have between age 2 and 10 of either sex, ASA grade 1 and 2, posted for pediatric surgery under GA, general anesthesia. And those patients whose parents guardian were willing to give consent were included in the study. The patients which were excluded were ASA grade 3 and 4 who had reaction or hypersensitivity or contraindication to clonidine or midazolam, age less than 2 years or more than 10 years, who had history of nausea, vomiting or retching before anesthesia, were excluded from the study. Pre-anesthetic checkup was done before the procedure, and informed consent was taken from the parents for this procedure. 60 patients were allocated in two groups. Group A included clonidine, 3 microgram per kg 60 minutes before the procedure. In group B, midazolam was given 0.5 mg per kg 60 minutes before the procedure, and they were assessed on the basis of pediatric separation anxiety score in a 4-point scale: easy separation, whimpers but easily assurable, cries and cannot be easily reassured, poor crying and clinging to parents. Mass acceptance score was also considered, which had 4 parameters: 1 excellent, 2 good, 3 fair, 4 poor. 1 and 2 was considered satisfactory, 3 and 4 considered non-satisfactory. Sedation score, there were 2, does not respond to mild protruding or shaking, 2 responds only to mild protruding and shaking. Wake-up behavior studies: first, calm and cooperative; 2, not calm but would easily be calm; 3, not easily calm, moderately agitated; 4, convective. 1 and 2 were considered satisfactory, 3 or 4 were considered not satisfactory. Data was collected and entered into Excel sheet, and Pearson crest and unpaired t-test was applied. Result: the mean PSS in oral clonidine and midazolam was compared. Higher mean PSAS, pediatric separation anxiety score, as compared to oral clonidine. In mean mass acceptance score was compared between oral clonidine and oral midazolam, showing a higher mean mass acceptance score in oral midazolam group in comparison to oral clonidine. The comparison of mean heart rate was done and was not statistically significant. The comparison of oral clonidine and sedation: all clonidine group has sedation grade 2, and oral midazolam, all patient has sedation grade 1. That means the group were dependent on sedation grade. For wake-up behavior, there was statistically significant association between the wake-up behavior and the group showing are dependent on wake-up behavior. Clonidine had better wake-up behavior than midazolam. Discussion: in our analysis, we found oral clonidine is better and effective for parent separation anxiety and in comparison to midazolam. In our analysis, we also found oral clonidine is better and effective for mass acceptance and in comparison to oral midazolam. Oral clonidine hemodynamic period heart rate blood pressure was lowered in comparison to midazolam, and in oral clonidine there was better wake-up behavior and sedation score in compared to oral midazolam. Conclusion: oral clonidine 3 microgram per kg is an effective and safe alternative for pre-medication children undergoing surgery under general anesthesia. It decreases anxiety levels, better parent separation, and results in better mass acceptance at the time of induction when compared to oral midazolam. Oral clonidine had better sedation wake-up behavior, works without causing much side effects or post-operative complications. These are my references. Thank you.
Thank you, all the participants. You all are presenting very well. So, time to the question answer session. Are you ready? Okay. My first question to the Mr. Santosh Kumar.
Hello, sir. Good morning, sir.
Santosh Kumar Legeri.
Yes, sir. Good morning, sir.
Why early feeding group is better, and what are your statistical score?
So on the statistical score wise, the incidence of PONV was lesser in earlier feeding group as compared to conventional feeding group, even though the number of patients who omitted in early feeding group was lesser, but the difference was not statistically significant, sir. So we recommend, so there is no unnecessary delaying the post-operative feeding in children. So we suggest the patient should be given the feed as soon as possible when the child demands and when the patient is conscious and alert, sir, when his swallowing reflexes are intact.
Okay. So time is less. So very nice presentation. Thank you,
Thank you,
Mr.
sir. Thank you so
Santosh.
much. Thank you so much.
Second one is Doctor, please second. Who
Sir,
present
me,
the
Dr.
micro? Doctor?
Priyanka. Good morning, sir.
Dr.
Priyanka,
Priyanka.
sir.
Okay. Okay. Full name?
Priyanka Singh, sir.
Priyanka Singh. You are from? Which
Sir,
institute?
I'm from Bihar. Sir, my UG is from Kolkata, sir.
Which institute? From?
Sir, STMC.
Okay, okay. So very nice presentation. What is your take-home message, doctor?
Sir, by using
Pediatrics endotracheal tube is better than uncuffed cuffed tube, no? Your studies.
yes, sir.
Okay. So what is
Yes, sir.
your take-home
Sir,
message?
there is less airlift and tube exchange rate was also low. As my study, I was conducting my study in prone position, so there were chances of accidental dislodgement of the tube. So by using cuff tube, we can prevent that. And also there is less chances of multiple time of laryngoscopy. So, sir, cuff tube was better.
Cuffed tube is better, yeah, uncuffed tube is better.
Sir, cuff tube.
Okay. I'm going to ask question from Prabhavati Srinivas. Thank you, Priyanka.
Hello, sir. Morning, sir.
Thank you, sir.
What is your study?
So my study is comparison of ultrasound guided suprazygomatic maxillary nerve block for children undergoing cleft palate repair, comparing the dexmedetomidine with bupivacaine and bupivacaine alone, sir.
So how to calculate the CHIPS score in your study?
Sir, we saw the chip score once the babies arrived in the PACU. We started seeing the chip score for every 30 minutes up to 2 hours in the PACU. After 2 hours till 24 hours in the ward, sir. The chip score is more than 3. We consider the pain was insignificant, so we can give that analgesic fentanyl in the PACU up to 2 hours. Afterwards, in the ward, we will give 15 mg per kg paracetamol, sir.
How to calculate aesthetics? Your
Sir, I didn't.
no, what statistical based analysis? No, tell
Sir,
about.
We concluded with the chip score and that post-operative pain score as a chip score, sir. Then analgesic requirement is a fentanyl and paracetamol. In that, we consider chip score was significantly less than 0.05 in every 2 hour, 4 hour, 6 hour, 8 hourly, sir. So the pain score which used in the dexmedetomidine group is little lesser than that bupivacaine alone. So when adding to the additive into the block, it actually prolongs the duration and gives a better analgesic.
Okay. Thank you.
Thank you, sir.
Our fourth one is Rusda Rahman. Hello, Rusda Rahman.
Good morning, sir.
Good morning. What is your study?
My study was to compare the general anesthesia and the subarachnoid block in pediatric patient undergoing infraumbilical surgery with the neutrophil lymphocyte ratio.
Your study, so I think less chance of infection and less chance of increase of neutrophil count is in subarachnoid block.
Yes, sir.
Okay. What is your exclusion criteria?
Sir, in my exclusion criteria included the refusal of the patients, hemodynamic instability or other immunocompromised states such as hepatic diseases or liver diseases, renal, cardiovascular, any malignancy, coagulopathy, transfusion history. These are included in my study.
These are the included. Okay.
Excluded, sir. Sorry, excluded.
Excluded. Okay, okay. So how to calculate your statics?
Sir, the sample size was calculated using the previous study where power was kept less than 80%, around 80%, and the type 1 alpha error was less than 0.05. And it came out to be a total of 42 patients, and 21 patient was taken in the each group. And p-value should be less than 0.05 to be adequate, significant for analysis of the result. And t-test, independent t-test was applied to compare the groups.
What is t-test?
Sir, the two independent variable of the inter group were compared using the t-test.
Okay, thank you, Rasda.
Thank you, sir.
I think next in Ketki Khaskar.
Yes, sir. Good morning, sir.
What is your good morning? What is your topic?
So my topic was to compare the two methods, sir, age-based method versus the length-based method using the Broslow tape for estimating the accurate size of the endotracheal tube in children, sir.
How to select your tube size?
Sir, in my study, sir, during
another question: how to select your tube size, and what is your exclusion criteria, and what is your statistics?
Yes, sir. Sir, to select the yes, sir. To select the endotracheal tube size, sir, in the process of induction and intubation, sir, whoever was the senior anesthesiologist, they used their own method, whatever the method they chose, sir, for intubation, sir. And post intubation, whatever was the actually put ET tube, we compared it to the two methods, sir. That is the age-based method, which is for less than 6 years, age by 3 plus 3.5, according to the age-based method. And the second one, we compared the length of the child. In the pre-anesthetic evaluation, we had measured the length of the child, and using the Broslow tape as a measure for that, we compared what size the Broslow tape would have given, and we compared these two methods with the actually put ET tube, sir. So like this, the ET tube was selected, sir. And second, sir, in exclusion criteria, one was patients whose guardians didn't give consent for the study. Secondly, patients who had a known difficult airway and they needed intubation with different tubes like RAE tubes or the flexometallic tube. And rapid sequence induction and emergency surgery patients, they were the exclusion criteria, sir. And for the statistical analysis, sir, this was since an observational study, and the students' unpaired t-test was used for comparison, sir. And using that, the results were analyzed, sir.
What is your take-home message, doctor?
Sir, take-home message, according to our study, sir, the length gives a more better accurate estimate of the endotracheal tube size, especially in children, because the age-based overestimates gives a larger size tube for the Indian children. So the length-based is a better method for estimating, and length can be used in emergency situations as well, where the age and weight is not known. So the length would become a better aid for estimating the size, sir.
Thank you.
Thank you, sir.
Dr. Ketki. Okay. I'm going to ask to question to the Neha Adhyapak.
Yes, sir.
What is for last grading? Kindly elaborate.
Okay, so for last grading, it's a 3-point grading system, sir. Okay, in that grade 0, grade 1, and grade 2. In grade 0, in any position, there is no content. Like on USGs, in the sagittal plane, when there is no content seen in the gastric antrum, then it is considered grade 0. In grade 1, in one of the position, that is mainly the right lateral decubitus position, if there is content, then it is considered grade 1. In grade 2, it is in both the positions, that is supine and right lateral decubitus.
So chances of less pulmonary aspiration in group 1 patient.
Yes.
Yes.
Okay.
In
Okay.
group 0 and
Huh.
less. Then group 1 and grade 2, then higher chances. Grade 2 is highest. Hello. Yes, sir.
Of nasogastric aspiration.
Sir, I just missed it. The question.
Chances Perlas can't improve less chance of na pulmonary your study.
Yes, sir. Yes, sir.
Okay. How to calculate your statistical value?
I used chi-square, sir, for it's an ordinal variable and nominal variable comparison. We used chi-square. So these two variables were used and applied in the chi-square value, and we got a value less than 0.005.
Oh, okay. Thank you, Dr. Neha Adhyapak.
Thank you, sir.
Going to ask a question to Dr. Pani Vasudevan.
Good morning, sir.
Good morning, Vani. Very nice presentation. My question to what is your on discussion?
Yes.
What are your take home message? Oh.
Sir, actually, there are very few studies available in pediatric age group. So according to my study, there was no significant difference found between VCV and PCV-VG modes of ventilation in supine position. However, there was a marginal advantage with PCV-VG mode of ventilation in Trendelenburg position, sir.
So PCV-VG mode is better than VCG mode. Okay.
Yes, sir.
Okay. What is your inclusive criteria?
Sir, I included the patients who were scheduled for elective laparoscopic surgery belonging to ASA class 1 and 2 of both genders and from neonates to 15 years of age, sir, and who gave valid informed consent.
Okay. Thank you, Dr. Vani.
Thank you so much, sir.
So my next question to Dr. Sri Hari. Dr. Sri Hari.
Good morning, sir.
Good morning. Your study nebulization with dexmedetomidine comparison to nebulization with normal saline. Okay, normal
for
saline.
parental separations.
Okay, okay. So how many patients you have study in this group?
So totally we took 90 patients, sir, divided into two groups of 45 children we gave dexmed nebulization and other 45 we gave normal saline nebulizations.
So nebulization with dexmedetomidine is provide better parental separation in the pediatric patient and less chance of the sedation post-operatively.
Yes, sir.
Okay. So what is your statistical value? How to calculate?
Sir, we used student t-test to determine the significance difference between the two variables, and our p-value we took was less than 0.05, and our p-value of the study came to be 0.02. So study statistical significance.
So what is a student t-test? How to calculate?
Sir, here the two variables are compared between the two groups, sir.
Mm-hmm. Okay, okay. Thank you, Dr. Hari.
Thank you, sir.
Okay. Nah. Okay, I'm going to ask next question to the Neha Sinha. Neha Sinha.
Good morning, sir.
Good morning. So, what is your study?
Sir, we compared ultrasound and standard auscultation in children and determining the accuracy and rapidity of both the techniques
Okay.
to find the placement of the ET tube.
Yeah. What is lung sliding sign?
Sir, when both the pleura slide over each other, we see it as a shiny line sliding over each other. That is the lung sliding sign.
What is significant of lung sliding sign?
Sir, positive ventilation. We can see when the lungs are getting inflated.
Okay.
Yes, sir.
What is Keen's formula?
Sir, Kien's formula for determining the size of the tube in children, the internal diameter. So we use this as our technique to determine the cuff tube size. Yes, sir.
Why not you study for ultrasound versus for confirmation of the position of the ET tube with
Yes.
echo ECO2. I think
Sir, ETCO2, we kept ETCO2 as gold standard. Sir, also sometimes in children there is a study that shows that when the tube is intragastric, false CO2 detection is also there sometimes, which can result in false ETCO2, which can be
conventional auscultation is better comparison to the ultrasound, no?
Sir, in our technique, in case of accuracy, ultrasound was found to be better, but in terms of the time taken, conventional auscultation was way faster.
Okay. So how to calculate your statistical value?
So we calculated based on the previous studies, which was actually done in adult patients. There was no studies in pediatric patients. So for a sample size of 75, the 80% power could come from the study. So sir, we took as a 75 sample size for patients.
Okay, thank you, Dr. Neha.
Thank you, sir. Thank you.
Now I'm going to ask our last participant, Dr. Krishna Dalani.
Good morning, sir.
What is your study, Dr. Krishna?
So my study is about
Karishma.
Ji, sir.
Are you Karishma? Okay.
A comparative study of oral clonidine and oral midazolam as pre-medication in pediatric surgery to study mass acceptance and parent separation.
Okay.
And other variables.
What is other useful advantage of the oral clonidine over oral midazolam?
Sir, with oral clonidine, the patient hemodynamically was more stable and the patient had better wake-up behavior with clonidine and no respiratory depression intra.
I think oral midazolam also some insignificant respiratory depression.
Sir, in midazolam, there was in 1 or 2 patients out of 30 patients, but in clonidine, the patient was more hemodynamically stable throughout the procedure.
Okay. So, how to calculate your statistical value and what is your exclusive criteria?
Sir, my exclusion criteria was I included patients, excluded the patients who were less than 2 years of age or more than 10 years of age. And ASA grade 3 and 4 were excluded, and patient who did not give consent, the parents who did not give consent and refusal, and who had contraindications or hypersensitivity reactions to earlier use of clonidine and midazolam, or nausea or vomiting with that.
Okay, thank you, Dr. Karishma.
Thank you, sir.
So I say much better presentation by all 10 participants. Thank you very much. And kindly present during you all during the valedictory function after the lunch for the result. Thank you.
Thank you, Dr. Manoj, and thank you all the participants. Best of luck to all the participants. And my name is Dr. Dilip Ranparia. I am President-elect of ISA Surat City Branch. And on behalf of Surat City Branch, I would like to thank Organizing Committee of ISACON. Thank you.
Thank you, sir.
Thanks to technical team and audiovisual partner also.
Now next session is 11 o'clock.
ನಿನ್ನೆ ನಮಗೆ ಕೇಳ್ಬೋದು ಸರ್ ಒಂಥರ ಜಡ್ಜ್ ಮಾಡ್ಬಿಡ್ತಾರ ಅಂತ ನೀನ್ ಕೇಳಿದ್ನಲ್ಲ ಹಂಗೆ
Okay, now second session will start. This session is ISA Trainee Talent Award, and I invite Dr. Joya Shankar Jana, Dr. Anjali Bhure, and Dr. Neeru Luthra. Okay. Please start the speakers. First participant, start.
Hello. Very good morning, all the speakers. This is about 10 speakers we have today. And I welcome my co-chairs and co-judges. Very good morning to you all. And
very good morning.
Yes, Niru, have you? We can't see you. Yes, we can see you now. Very good morning, madam. So
Good morning, sir. Good morning.
Good morning. So we'll welcome the first speaker, Dr. Namrata. If you are ready, you can start. Namrata, you are logged in? Yeah. So you know all the rules, Namrata? Can you hear us, Namrata? Recorded it? Okay.
Okay, fine.
Start.
A very good morning to everyone. Anesthetists handling the neonates should have excellent skills and knowledge because experience of the anesthetist is one of the most important factors determining the risk. Neonates includes the babies within the first 44 weeks of post-conceptual age. Age-specific and case-specific challenges make the management of the neonates more challenging. Suppose you're in an emergency duty and you receive a call from a pediatric surgeon about a 5-day-old term neonate with abdominal distension suspecting intestinal obstruction posted for emergency laparotomy. So what are all your concerns? These neonates are prone for upper airway obstruction. Looking at the external appearance, they have a prominent occiput. When made to lie supine, head gets flexed and causes obstruction. They're obligate nasal breathers. Any nasal obstruction makes the breathing difficult. Tongue is very large relative to mouth. When the baby loses its consciousness, it obstructs the patency of the airway. The larynx of the neonates is placed anteriorly and higher up. The cricoid ring is narrower than the glottic opening. The tracheal and the laryngeal diameter is very narrow compared to that of the adults. Slight edema increases the significant obstruction. Omega-shaped floppy epiglottis makes the intubation difficult. Therefore, preset the ventilator to prevent barotrauma. Shoulder roll to be used. Stabilize the head in the neutral position. Gentle cricoid pressure. Care to be given for accidental extubation because slight flexion or extension of the head causes misplacement of the ET tube. These neonates have reserve. The functional residual capacity is less than that of the closing capacity and are prone for atelectasis. The fetal hemoglobin has more affinity for oxygen and the consumption of the oxygen is twice that of the adults. The lung compliance is very bad, whereas the chest compliance is very good among the neonates. The diaphragm is the primary muscle of ventilation but lacks type 1 muscle fibers. All these factors causes the babies to undergo easy fatigable and rapid desaturation. Infants cannot tolerate hypoxia and are prone for bradycardia and cardiac arrest. Important thing is the postoperative apnea, which happens most commonly in the first 12 hours. Apnea for more than 15-second duration and is associated with bradycardia and desaturation. Cardiovascular system. At the time of transformation from the fetal to neonatal circulation, there is marked increase in SVR and decrease in PVR. In the neonates, myocardium is less contractile. Therefore, left ventricle becomes very less compliant and limits the stroke volume. The cardiac output is thus heart rate dependent. Neonates behaves as with a fixed cardiac output state. Since the neonates have a predominant of the parasympathetic tone, they're prone for bradycardia and reduced cardiac output. BP is low at birth. This is secondary to low systemic vascular resistance. These neonates have reduced catecholamine stores and blunted response to exogenous catecholamines also. Hypotension without tachycardia is a hallmark of intravascular fluid depletion. CPR in the neonates is initiated soon when the heart rate is less than 60 beats per minute. If there is a single rescuer, use two-finger technique. If there are two rescuer, you can use both the hands to wrap around the chest of a baby as shown in the video, and chest compression is given using the thumb. In both the scenarios, the ratio is 15 compression is to 2 breaths. Coming to the renal system, where because of the reduced tubular and concentrating capacity, the newborn kidneys have limited capacity to compensate for the volume excess and depletion. Judicious must. Because of immature degradation reactions and less availability of the plasma protein, there is long half-life of the drugs and increased availability of the free drugs. Reduced hepatic glycogen stores and premature gluconeogenesis make the babies prone for hypoglycemia and in turn is a risk factor for seizures. Glucose monitoring and use of dextrose-containing fluids is to be given importance. Because of the large surface area to weight ratio with minimal subcutaneous fat and immature shivering and sweating mechanism, they're prone for hypothermia. Hypothermia adversely affects causing respiratory depression, acidosis, decreased cardiac output, and decreased platelet function. Incubators for transport, warming, IV fluids, mattresses, plastic wrapping helps prevent hypothermia. Blood-brain barrier is poorly formed. Drugs causes this blood-brain barrier and has prolonged and variable duration of action. Because of the unmyelination and reduced size of the nerve fibers, they have rapid onset of nerve blockade using dilute local anesthetics. Cerebral fragile and prone to intraventricular hemorrhage. They have decreased pain threshold. Therefore, practicing multimodal analgesia and regional block techniques have a better outcome. More studies are required as anesthesia is a neurotoxic to the developing brain and they pose a risk factor for developing neurocognitive disorders. To conclude, almost all neonatal surgical emergencies are urgencies and not emergencies. So having a better knowledge on physiology and waiting for 24 to 48 hours to stabilize and allow for the better fetal to neonatal transition helps with a better outcome of the neonates. Thank you.
Very nice talk, Namrata.
Thank you, sir.
Thank you. And do you routinely do these cases in your hospital?
Yes, sir. I am a postgraduate from Bangalore Medical College and Research Institute. We have a super specialty hospital with a separate unit for pediatric surgery, sir.
Okay,
We do all kind of neonatal surgeries, sir.
Okay. So what are the other ways to do hemodynamic monitoring in
Yes, sir.
emergency in a neonate?
Sir,
Yeah.
hemodynamic monitors, apart from the standard ASA monitors, we also monitor the art lines, sir. Invasive blood pressures monitor.
No, Namrata, just sorry to interrupt you. I am asking how do you do hemodynamic, not just monitoring of pulse and BP,
Yes,
of
sir.
blood volume and intravascular volume. How do you monitor that?
Intravascular volume, we also monitor with the pulse pressure variation, sir, cardiac output monitoring, and also the pleth variability index from the Massimo, what we use.
Do you have a cardiac output index monitor, non-invasive?
Non-invasive, we don't have, sir. Like transthoracic esophageal echo, we don't practice intraoperatively, and transesophageal echo also we have. It is just we have seen, sir, but we don't. I have not per se have seen, sir.
Because it's a neonate, that's why I'm asking.
Yes, sir.
So do you monitor the urine output also? That is a very good indicator.
Yes, sir. Urine output, yes, sir. Intravascular.
You have to tell that.
Okay, sir.
Luthra madam, your questions, please. Please unmute yourself, Luthra madam.
Doctor.
Yeah, you're unmuted. Yes.
Nice presentation, Namrata.
Thank you, ma'am.
So do you also have a post care ICU for these patients?
Yes, ma'am. Pediatric ICU is there, ma'am. Post-operatively, we shift the neonates with an incubator back to the ICU, ma'am.
So do you keep your patients on ventilator or do you extubate the patients on table?
Ma'am, it depends on the case, ma'am, what case we are doing, and also depends on the hemodynamic monitor at the time of extubation, condition of the patient. Many cases we do extubate and send them back to the ICU, and many cases require...
Just a minute. What should be criteria for extubation of a neonate?
Ma'am, criteria for extubation of the neonate is hemodynamic stability of the patient, and also the surgery which demands, like VST correction surgeries and all, the post-op ventilation for 4 hours is required. And if the baby's tone activity, if it is reversed, we can extubate the patient, ma'am.
One more thing is hypothermia. If a child is hypothermic,
yes,
a neonate can't be extubated if it is hypothermic.
Yes, ma'am. Yes, ma'am.
Thank you.
Thank you.
Dr. Namrata, nice presentation. I would just like to ask you what commonest complications which you have come across in neonatal emergencies?
Ma'am, commonest complication is that is postoperative apnea. In many cases, after extubating also, we have reintubated the patient, ma'am. That is what common complications we have observed.
Okay, so what are the strategies which you follow for such complications?
Ma'am, strategies is that after extubating the patient, we observe the patient on table for few minutes, and after like patient has gained full if all the parameters are normal, and then we shift the patient outside the OT, ma'am. And also we maintain this look for any obstruction of the airways, and after clearing that, we shift the patient out of the OT.
Okay, thank you. Thank you, Namrata.
Now we'll go to the next speaker.
Dr. Nehal.
A warm welcome to everyone present here. Let's start with the case scenario first. A 56-year-old woman was posted for laparoscopic cholecystectomy. She was just a known hypertensive. Anesthesia was induced with propofol, sufentanil, and rocuronium. Patient was then intubated and put on mechanical ventilation. But as soon as rocuronium was given, patient developed generalized erythema with cardiovascular collapse. She was treated with IV crystalloids, ephedrine, and adrenaline. No further vasopressors were required, and patient was stabilized. This is clearly a case of anaphylaxis in the perioperative period, which will be my topic for today. So the mortality rate is very high, that is 3.8 to 4%, which makes it very important for us to know about it. So these reactions are mainly hypersensitivity reactions, which are further classified into allergic and non-allergic. These allergic reactions are further classified into immediate, mediated by IgE antibodies, and next is the delayed type mediated by T-cell antibodies. These triggers could be anything in the perioperative period, but the most common are neuromuscular blocking agents and antibiotics. In the neuromuscular blocking agents, rocuronium is the most common. Morphine, thiopentol, etc. are known as the sensitizers. In antibiotics, penicillin and cephalosporins are common. Other causes are dyes like methylene blue, antiseptics, colloids, contrast agents, sugammadex, or latex allergy. Coming to the pathophysiology, when the patient is exposed to an allergen, plasma cell is primed to produce IgE antibodies which sit on the mast cell. On further exposure, bodies gets interlinked, and this results in mast cell degranulation with the release of bradykinin and histamine. The clinical features are mainly based on Ring and Mesmer grading scaling, wherein it classifies these patients into 4 grades. Grade 1 and grade 2 are milder grades, wherein there is generalized mucocutaneous signs and multi-organ manifestations. Whereas grade 3 and grade 4 are quite intense, with severe life-threatening multi-organ manifestations like arrhythmia, cardiovascular collapse, and even cardiac arrest. So coming to grade 3, there is cardiovascular collapse due to intense vasodilatation. In order to match oxygen demand ratio in the myocardium, there occurs paradoxical bradycardia caused by Berzol-Jaric's reflex. In this case, if we give atropine, which causes tachycardia, this myocardial oxygen demand ratio will be impaired and patient will further deteriorate. Associated features could be erythema or urticaria. If these cutaneous signs appear in grade 3 patients, they could be considered as a sign of hemodynamic restoration. There might be associated bronchospasm. Grade 3, all in all, is an impending cardiac arrest scenario. In grade 4, patients are usually in circulatory arrest. If they are in acute coronary syndrome, then it is called as Kunis syndrome. Patients are usually having pulseless electrical activity as their rhythm due to severe hypovolemia. Coming to the management, it is mainly by starting with withdrawal of the cause, followed by volume resuscitation, IV adrenaline, and airway management. So in airway, if the anaphylaxis is caused due to neuromuscular blocking agent, airway has to be secured. If we don't know the cause, we can provide face mask oxygen. If the patient further deteriorates, definitive airway must be taken care of. In volume resuscitation, first 15 minutes of anaphylaxis causes 73% of blood volume drop. So with the help of large IV bore cannula, crystalloids are infused at the rate of 20 to 30 ml per kg, followed by colloids. In adrenaline, there are 2 regimens. In grade 3 patients, 100 microgram bolus can be repeated thrice, followed by infusion of 0.05 to 0.1 microgram per kg per minute. But in grade 4, a 200 microgram bolus is given. If the patient doesn't respond, CPR is started. Adjuvant therapies, no role for antihistamines or steroid. Bronchospasm is usually treated by adrenaline, salbutamol or terbutaline. In case of refractory hypotension, vasopressors can be started. In that, vasopressin is preferred over the rest because the rest are desensitized by adrenaline infusion. Coming to secondary evidences, after the patient has been stabilized, these can be done. That is histamine and tryptase level examination, RAS, that is radioallergen sorbent test, serum IgE levels, and skin test. In conclusion, diagnosis can be missed because this is of rapid onset. Management is mainly by clinical presentation by the patient. IV fluids and adrenaline are the mainstay of treatment. Comprehensive assessment and thorough history of the patient ensures patient safety in further procedures. These are my references. Thank you.
Yeah, good presentation.
Thank you, sir.
Thank you. So, what was the cause for this anaphylaxis in your case? Is
Hello.
it rocuronium or something else, or was it antibiotics?
Rocuronium, sir. I have not mentioned in the case scenario that they had given any antibiotics. As soon as rocuronium was given, patient had a cardiovascular collapse, sir.
So are you sure that it was because of rocuronium or nothing else? What was the induction agent? Propofol?
Propofol, sir.
So even propofol can cause anaphylaxis.
Yes, sir. But
It is having this soybean oil. So during history taking, did you take any history of all this allergens
yes, sir.
or
We did.
allergic history?
Yes, sir. She didn't have any history to any soybean oil, vegetable oil, or any egg protein as well. And literature has said that these propofol, even though it can cause anaphylaxis, it can cause only grade 1 or grade 2 type, because the molecule ring could be a sensitizer. So, looking at the clinical history, rocuronium was found to be the impending agent, sir.
Dr. Neeru, would you like to ask question?
Dr. Nihali,
Yes, ma'am.
suppose this patient comes to you again for a surgery, again planned for maybe a laparoscopic hysterectomy. What precautions will you take the next time?
Ma'am, first after this scenario has happened, the patient was allowed to go for serum tryptase level examination and serum histamine level examination, RAST, everything, which wherein she was found to be sensitive to neuromuscular blocking agents. So next time the patient must be well prepared, and I must make sure that patient is given a dose of steroids priorly, because steroids has no role of any immediate role in acute anaphylaxis, but it has a role in maintenance, and that is management of the patient. And second, I should not be using rocuronium, that is non-depolarizing muscle agents, and I should use a neuromuscular blocking agent which doesn't have a lot of histamine releasing property as well.
Which one will you use?
I would use vecuronium, or I would use vecuronium.
Vecuronium also has the same properties. Is it like rocuronium? What about cisatracurium?
Cisatracurium also can be used, sir, but
No, what would you use? Because you have already confirmed that the patient has anaphylaxis because of rock. So what is the precaution, or rather what will be the bold statement given in the discharge card that she has allergy to rocuronium? So be careful where she goes away for any other surgery at any other hospital. So you have to mention that in the discharge card. So which would be the agents which is in the group of rocuronium which should not be used?
In the group, we cannot, after rocuronium, atracurium and pancuronium are known to be most anaphylactic causing agents, sir. But among the groups, vecuronium and cisatracurium are found to be more safer, sir.
Okay.
Thank you, Nehali.
Thank you, ma'am.
We come down to the third speaker, Dr. Nivedita. Can we have your presentation, please?
Hello, I'm R.K. Nivedita. I would like to discuss some of the important theories in anesthesia. The exact location and mechanism of action of anesthetic drugs is unknown, although much research has been done in this area. A number of theories have been proposed to explain the anesthetic action, include the lipid theory, the protein theory, and the biochemical theory. Let us discuss the lipid theory first. There are 4 important theoretical touch points in lipid theory. The Mayer-Overton theory is the first. The Mayer-Overton theory, it is a unitary theory of anesthesia first introduced in the year 1901. It states that the anesthetic potency varies directly with lipid solubility. Higher the lipid solubility of a drug, greater is its anesthetic potency. In this theory, the anesthetic drugs cross the highly lipid-soluble membrane and cause disturbances in the physical structure of the membranes, thereby inhibiting depolarization. The above graph shows the relationship between the anesthetic potency and the oil-gas partition coefficient. According to Mayer-Overton theory, increasing the chain increases the lipid solubility and leads to a corresponding increase in anesthetic potency. However, beyond a certain chain length, the anesthetic effect disappears, which is shown in this figure here. The cutoff occurs at a carbon chain length of 13 for alcohols and between 6 and 10 for alkenes. Lilly later identified a potential problem with the Mayer-Overton hypothesis. She said that the correlation between the anesthetic potency and lipid solubility is impressive only for a certain group of compounds, and exceptions to this rule exist. These exceptions are categorized into three. Low lipid soluble potent anesthetics, example alpha chlorelose and chloral hydrate. High lipid soluble non-anesthetic, example fluorothyle, and equal lipid soluble unequal anesthetic potency, example anesthetic optimal isomers. Hence, the Mayer-Overton theory has been discarded. Now coming to the Pauling and Miller theory. This theory is also known as the hydrate theory, introduced in the year 1961. According to this theory, the anesthetic agents bind itself to hydrated crystal-like structures. These crystal hydrates are formed when water molecules are linked together by strong hydrogen bonds and take on the crystalline structures. This leads to the impedance in the ionic mobility, chemical and enzymatic activity of the brain. Now coming to the membrane fluidization theory. This is also known as the lateral phase separation theory. Anesthetic agents dissolve in the lipid bilayer to cause its loosening. This anesthetic-induced fluidization does not cause conformational changes in proteins that are important for events such as synaptic transmitter release and binding of neurotransmitter to receptors. Now coming to the membrane expansion theory. This is also known as the critical volume hypothesis. As shown here, the bulky and hydrophobic anesthetic molecules accumulate inside the hydrophobic regions of the neuronal lipid membrane, causing the membrane to expand. This expansion alters the function of membrane ion channels, providing the anesthetic effect. Based on this theory, it is suggested that Mayer-Overton correlation with potency can be improved if molecular volumes of anesthetic molecules can be taken into account. Now coming to the protein theory. The protein theory was proposed by Franks and Leaf in 1980. They propagated that the general anesthetic agents interact with the hydrophobic sites in certain proteins. The most target proteins are ion channels. As shown here in the figure, anesthetic agents bind to G protein coupled receptors, which are the cis-loop flux. Cis-loop receptors are nothing but a superfamily of inhibitory receptors such as GABA and glycine, and excitatory receptors such as serotonin and glutamate receptors. This is the basis for the protein theory. The anesthetic agents act on the membrane proteins in a lock and key fashion as shown in this figure below. Now coming to the biochemical theory. Anesthetic agents act by inhibiting the glucose metabolism, interference of ATP production, and interfering in the oxygen utilization and cellular respiration. This is the basis of biochemical theory. This was a short overview about the three broad theories based on which most modern theories have evolved and helped further our understanding of anesthetic functioning. Thank you so much for listening.
Nivedita, that was a good presentation. I would just like to ask you, how can you clinically imply, oh, you're here. How can you clinically imply these theories, lipid, protein, and biochemical?
Most of the IV anesthetic drugs that we give today, they are acting on the specific receptors. So all receptors are protein. So G protein coupled receptors, they are derived from the protein theory. That's what I want to do.
Dr. Neeru, you can ask.
Very difficult topic to choose for a presentation, I would say. Full marks for that. Well done.
Thank you, Nivedita. Dr. Prerna, can we have her presentation, please?
Good morning. So the topic is minimum alveolar concentration of inhalational agent utility in the clinical practice. Reading from my side. The practice of surgery predates human civilization, and the idea of anesthesia is as old as the surgery. We can see even it in the biblical creation, where the God snatched the rib of Adam deep sleep. Until about 150 years ago, having surgery was a very horrible experience, and this is no longer the case thanks to our community, the anesthetists. Since the discovery of the inhaled anesthetic agent, the need for the method to measure and assess potency becomes a drive. Assessment of the depth of anesthesia was previously based on the clinical assumption as purposeful movement was said to be the sign of consciousness. To refute the statement, patient may have no recall during the movement, and second, movement is a spinal reflex and movement does not correlate with the recall. Again, sympathetic stimulation is predicted by PRS scoring as in BP, heart rate, sweating, and tear formation, but sign and symptom is not reliable detecting awareness during general anesthesia, as activation may even occur in the presence of adequate anesthesia. So these early method of qualitative assessment varies with different anesthetic agent, thus limiting the utility and anesthesia. Therefore, Eger et al. Used the concept of minimum alveolar concentration in 1965, which relates the concept of concentration and partial pressure of inhaled anesthetic agent to clinically significant endpoint. So what is MAC? It's the minimum volume percent of an additional agent at 1 atmospheric absolute, which prevent the movement to standard surgical stimuli, typically 1 centimeter width and depth insertion in 50% of the population when breathed in oxygen in absence of any other analgesic or anesthetic drug. Now, how do you estimate? From the equation, we can see that max times the lambda is equals to 1.82 atmosphere. Lambda is the oil gas partition coefficient. This equation represents the product of MAC and lambda is constant for commonly used inhalation anesthetic agent. And why so? Because volatile anesthetic potency varies differently and directly with the lipid solubility, which is explained by Mayer-Overton equation. It works on a principle of membrane disruption hypothesis, which says that disruption of lipid bilayer affects the function of membrane protein, interrupting the neuronal trafficking. Now, counter statement is rise in the temperature also disrupt lipid membrane without inducing the state of anesthesia. Again, a patient with a high lipid solubility exerts no anesthetic effect. Lastly, in graph, we can see that the line does not pass directly through the point. Therefore, there's a line of death fit and relationship is not perfect. Now, is determined plotting the patient not moving in response to noxious stimuli in y-axis and anesthetic concentration in x-axis creates a dose response curve. We can see that the curve is steep, that is, there is relatively little variability in the concentration of inhaled anesthetic agent. MAC corresponds to the concentration of anesthetic at which 50% of the patient does not move in response to stimuli, and the standard deviation we can see is a 10%, and 1.2 MAC produces immobility in 95% of the patient. Next, inhaled anesthetic agent suppresses the movement by action at a site other than the cortex, and there is lack of association between cortical electrical activity and immobility to noxious stimuli. The major advantage of being it is a reliable index of anesthetic potency. And how? Because end-tidal anesthetic partial pressure coefficient is an accurate reflection of alveolar partial pressure and relevant endpoint of general anesthesia, which is immobility to surgical stimuli. Now, it also helps in comparing the factors affecting the inhalation. Very easy measure by infrared absorption analysis. However, nothing comes without limitation. MAC is not a reliable indicator of hypnosis and consciousness. Anesthetic concentration that suppresses the goal-directed motor response to verbal stimuli do not necessarily produce unconsciousness. A recent review of a study, isolated forearm technique, suggests that MAC, which is a measure of responsiveness, may not necessarily be informative regarding the state of consciousness. Again, MAC awake is also unreliable due to the behavioral component of the response. Parental anesthetic agent cannot be assigned a MAC value, and therefore it is difficult to compare the potency between the parental and the initial agent. Lastly, the outcome in a spectra of risk recall is useful in preventing intraoperative awareness with the explicit recall. No regulatory body has confirmed the clinical superiority between processed EEG and MAC in terms of awareness. A large randomized trial Michigan awareness control study which recruited 2463 patients supported this. Mortality after non-cardiac surgery was associated with a triple low state and a significant predictor of perioperative mortality. Triple low state is a BP less than 75, low BIS index of less than 45, and low MAC value less than 0.70. At last, I want to quote WTG Morton, sir, the state should, I think, be called anesthesia. Thank you.
Good morning, sir.
Good morning. It was a very super fast, like a bullet train. I really could not get what you're talking, and I'm sorry, you should be a little bit slow in your audio and the speaking speed was terribly fast. Dr. Luthra, madam, you could understand anything? What could she say?
I was just assuming something because the screen is not very clear. I can't even see the things.
Yeah, and the audio was too fast.
Yeah.
Anyway, you always keep learning, and
okay, thank you, sir.
you always get some experience. The more amount of presentations you do, your slides has to be more explicit. Your audio has to be more clear, not that fast, because this is running very fast. You cannot match your speed of your audio with the slides. So please practice that also.
Okay, sir. Thank you, sir.
Thank you.
Thank you.
I have a question for you.
Please.
How do you correlate the volume percent set on the dial of the vaporizer with the MAC? Because you can't see the MAC, no?
Yes, ma'am. Ma'am, with the hemodynamic parameter, we can assess that. Like the increase in the heart, the cardiac, this hemodynamic parameter, the blood pressure decrease, and because all of the MAC value, there was a graph given, and all of them are in the, a formula is given for it. Because MAC into 1.82 times is a linear correlationship. So exactly, we don't have the clinical scenario. Like BIS, we can monitor the awareness, we can monitor with the BIS, but for the MAC, it in the new ventilatory setting, it comes on the monitor that how much MAC is being delivered, but indirectly we can assess that.
But parameters like hypotension can have many causes.
Yes, ma'am. Due to drugs also.
You need to study all this. Thank you.
Okay, thank you, ma'am.
Okay, we invite the next speaker, Dr. Raghav. Yeah.
A very good morning to all. At the outset, I would like to thank the organizers for selecting me for ISACOON-2021 Trainee Talent Award session. Myself, Dr. Raghav Gupta, working as a senior resident in the Department of Onco-Anesthesia and Palliative Medicine at AIIMS New Delhi, would be presenting on the topic perioperative fluid management. The scope of my presentation would include physiology and fluid mechanics, goals and indications of fluid therapy, perioperative fluid management principles. Since ages, classic Starling models has been followed for fluid restoration, but now it no more holds its place in clinical settings. Rather, endothelial glycocalyx layer forms an important part of revised Starling models for fluid restoration, for fluid shifting and vascular permeability. This layer seems to be damaged during inflammation, surgical stress and trauma, thus affecting the overall fluid balance. What are the goals of IV fluid therapy? It is maintenance and restoration of tissue fluid and electrolyte homeostasis and maintenance of central euvolemia, thus facilitating the tissue oxygen delivery. Thus, IV fluid should be given according to the individualized patient need and following standard protocols like any other pharmacological prescription. What are the indications of IV fluid administration? Resuscitation to correct hypovolemia, replacement to correct existing or developing fluid deficit, maintenance to cover daily water and electrolyte impairment, and fluid creep for drug dilution and to keep the catheters patent. What are the 4 important Ds of fluid management? We should be knowing that what type of fluid should be given for what indication, the dosing and the duration, and when we should be de-escalating the fluid therapy. Coming to the preoperative fluid management and fasting time, aim is to avoid the patient arriving in the OR in a hypovolemic or dehydrated state. Thus, it is important to give clear liquid within 2 hours of an elective surgery with an advantage of decreased thirst and hunger in the patient, decreased acidity of gastric contents, and decrease of the insulin resistance. During the intraoperative fluid management, Callum et al. In 1999 said that errors were the most common cause of perioperative morbidity and mortality. Thus, optimal intraoperative fluid management is important. In a landmark trial published in NEJM in 2018, that is the RELIEF trial, they have defined restricted fluid therapy as less than 1.75 liters per day, liberal as more than 2.75 liters per day, and a fluid balance is between the two. Why it is important? Because hypovolemia causes hypoperfusion, systemic inflammatory response syndrome, and sepsis, whereas hypervolemia leads to edema, postoperative ileus, nausea and vomiting, and pulmonary dysfunction. Why it is important that we should have an advanced hemodynamic monitoring during the intraoperative period. Literature says that individualized goal-directed fluid therapy using advanced monitor optimizes the stroke volume. The physiological response to hypovolemia is to maintain the pressure at the expense of flow. Thus, measuring the blood flow can alter the physicians to hypovolemia earlier than the pressure monitoring. In the right-hand side of the graph, we can see that if we divide the surgical risk into low and high, with the patient risk category being low and high, we should be using goal-directed fluid therapy in almost all the quarters, except if the patient falls into low risk category, with the surgery also being low risk. We should be aiming for a positive fluid balance of 1 to 2 liters and should consider shifting the patient to ICU if the patient falls into high risk category with a high risk surgery. The typical intraoperative goal-directed fluid therapy protocol focuses on stroke volume variation, the mean arterial blood pressure, and cardiac index. So if the variation is more than equal to 10%, we should be giving fluids. If the cardiac index is less than 2.5 liters per minute per meter square of body surface area, we should be giving inotropic agents. Otherwise, we should be using vasoconstrictors. So what IV fluid should be used? We should be giving isotonic balanced crystalloid solutions. 0.9% normal saline should not be used, as it is associated with hyperchloremic metabolic acidosis and acute kidney injury. The physiological rationale for using colloids is that they tend to remain in the intravascular space longer compared to the crystalloid, but still, since ages, the debate of crystalloid versus colloid continues. Bottom line is, we should be giving right fluid to the right dose to the right patient at the right point of time. Coming to the post-operative fluid management, early oral intake is encouraged. According to enhanced recovery after surgery protocol, we should minimize the post-operative contamination of IV lines, Foley's, drains, and NG tubes so that patient can be mobilized earlier. We should continue titrated IV fluid therapy in patients with impaired oral intake. In summary, I would like to say that an important area of responsibility for anesthesiologists is perioperative IV fluid therapy. Thus, it should be prescribed with extreme care as like any other drug. The stages to check for appropriateness of IV fluid therapy is meticulous assessment, right indication, proper prescription and management. We should encourage unrestricted fluid intake 2 hours before elective surgery of clear fluids. We should aim for a positive fluid balance of 1 to 2 liters at the end of surgery. We should optimize intravascular fluid volume before heading on to vasopressor or inotropic agents, and must use goal-directed fluid therapy in moderate to high-risk patients. These are my references. Thank you.
Yeah, very nice presentation, Raghav.
Thank you, sir. Good morning.
Yeah, good morning. How do you manage the blood loss? Because you just talked about the perioperative fluids. If the patient has blood loss, do you replace blood to blood, or do you replace with the balanced salt solutions or colloids?
Sir, we replace blood to blood, but as I'm working in a cancer case setup, so our threshold for transfusion of blood, because of the chances of, there have been studies that there can be cancer recurrence with blood transfusion. So we don't chase the hemoglobin to be 9 to 10. So even if the hemoglobin intraoperative through our ABG is 7, we initially tend to use crystalloids. But yes, if there is a rapid blood loss, which is leading to hemodynamic fluctuation, then according to the ABG values, we do transfuse blood by blood.
Dr. Neeru?
Yes, Raghav, very nice presentation.
Morning, ma'am. Thank you.
Good morning. Which fluid are you routinely using for all the surgeries?
Ma'am, we use balanced crystalloids, plasma light, and stereofundin preferably, ma'am.
Okay. I would like to add that saying that NS is contraindicated, maybe for ASA1 patient undergoing a lap chole, we are using these fluids. Yes, for a long duration surgery, you need not give lots of normal saline, which is not normal. So we can use these fluids, RL and NS, for a short duration surgery in an ASA1 patient.
Yes,
so all the PG sitting over there, we can't take a single message for all the patients.
Yes, ma'am, sure.
Thank you. Raghav.
Thank you, ma'am. Thank you, sir.
Hello, we come down to the next presentation. Saras Singh, can we have your presentation, please?
Welcome to ISACON Trainees Talent. This is Dr. Saras Singh, second year PG student from AIIMS Patna. I am going to deliver a talk on perioperative fluid management. Fluid requirement is a dynamic concept, and due to lack of robust evidence, fluid selection and administration often remains a clinician's decision. The following figure depicts the goal of perioperative fluid management. Our goal is to maintain adequate delivery and to avoid fluid excess that may cause volume overload or a fluid deficit that may lead to hypoperfusion of tissues and hypotension. American Society for Enhanced Recovery recommends to minimize nil per oral by encouraging oral clear fluids with 45 grams of complex carbohydrate until 2 hours preoperatively. Maltodextrin is most commonly used. This helps neutralize gastric acidity and improves metabolism to an anabolic state. Broadly, fluid administration can be based on estimation method, which is calculation based on patient weight, surgical losses, etc., or goal-directed therapy, which is by measuring and maintaining physiological variables using fluids. How do we choose between estimation or goal-directed therapy? The following matrix categorizes patients based on surgical and patient risk into 4 compartments. If both patient and surgical risk is low, goal-directed fluid therapy is not recommended, and a target of 0 balance is aimed for. However, if either of the risk is high, goal-directed fluid therapy is indicated and a positive balance of 1 to 2 liter is aimed for. If both the risks are high, goal-directed fluid therapy is recommended with positive balance of 1 to 2 liters, and post-operative SICU should be considered. Fluid estimation. Fluid calculation is based on maintenance fluid, which is calculated using Holiday-Segar formula, deficit, which is based on number of NPO hours, third space loss, which is based on type of surgery, replacement of losses, which is based on expected blood loss and intraoperative events, and compensatory volume expansion, which is outdated. Goal-directed therapy is a dynamic process targeting the key physiological variables are cardiac output and global oxygen delivery. This is used both perioperatively and in critical care settings. Post-operatively, we encourage early oral intake, and all the catheters that are deemed unnecessary are removed. In patients who require ongoing IV therapy, serum electrolytes are to be monitored, and continuous maintenance fluid, replacement fluid, and resuscitation fluid should be ongoing. To summarize, lack of clinical evidence in choice of intravenous fluid and guiding perioperative fluid therapy is a major challenge. Individualized therapy based on patient factors, surgery, and other special considerations have to be taken. Goal-directed fluid therapy may help for an individualized approach in perioperative setting. Thank you.
Nice presentation, Dr. Saras. One question I would like to ask you is, what should be the fluid strategy for ERAS?
Ma'am, for minor surgeries where the patient risk and surgical risk is low, we can use 0.9% NS or RL. And this has to be started either intraoperatively, or it could be also started preoperatively. Whereas for major surgeries, the fluid choice will depend on the type of surgery and the special considerations based on the patient risk.
Dr. Luthra, madam, your questions?
Your name is Saras, huh? Yes. So if you have an obese patient coming for, say, a laparoscopic cholecystectomy, duration of surgery is around 1 hour. How will you decide the amount of fluid to be given? The BMI is, say, 45.
It can be given according to the ideal body weight, and fluid calculation can be done accordingly. And since it is a minor surgery, I think estimation based on the calculation can be preferred.
So it is important you decide which body weight is to be used, okay? Not the total body weight for obese patient.
Ideal body weight, ma'am.
Take. Thank you.
Thank you, ma'am.
Thank you, Saras. Can we have the next presentation, please? Dr. Lavanya.
Good afternoon, everyone. Myself, Dr. Lavanya, and I'm going to discuss a study on the comparative study between the effect of opioid-free anesthesia and anesthesia in morbid obese patients. In the introduction, multimodal techniques for pain management involve 2 or more analgesic drugs. They target different pain pathways acting on central and peripheral nervous systems. The lower incidence of adverse effects and improved pain management may result in shorter hospitalization, improved patient recovery and rehabilitation. In the materials and methods, 40 subjects were included in this prospective randomized control study. Informed consent was taken and ethical clearance was obtained. In inclusion criteria, patients aged between 25 to 50 years of both sexes having ASA status and BMI of at least 35 were enrolled. Exclusion criteria, Patients on antihypertensive drugs, taking opioids for chronic pain, patients with allergies, patients with obstructive sleep apnea, unstable cardiorespiratory disorder, and hepatic and renal insufficiency were excluded. Patients were randomly divided into two groups. Group 1 included opioid-based anesthesia, where fentanyl was administered before induction. Group 2, opioid-free anesthesia, where loading dose of lidocaine, magnesium sulfate, and paracetamol were given before induction and maintained with infusion. All patients were monitored according to SS standard monitoring. Assessment parameters included demographic data like age, sex, BMI, and duration of surgery, perioperative hemodynamic changes like mean arterial pressure, heart rate, and oxygen saturation, visual analogs called pethidine consumption, postoperative complications were assessed. Sample size was justified according to medical caution. Independent sample t-test of significance, man-Whitney Z-test, and chi-square test was used. In the results, there was no statistically significant difference between both groups according to demographic data. Regarding heart rate, there is significant decrease in opioid-free anesthesia group compared to opioid anesthesia group. Regarding mean arterial pressure, significant decrease in opioid-free anesthesia group compared to opioid anesthesia group. No significant difference. Regarding VAS score, there is significant decrease in opioid-free anesthesia group compared to opioid anesthesia group. Regarding total pethidine consumption, there was significant decrease between the groups, which was lower in opioid-free anesthesia group compared to opioid anesthesia group. Regarding post-operative complications, there was significant decrease regarding hypoxia. This is the graph showing the oxygen saturation, VAS score post-operatively. This is the demographic data table. This is the heart rate. This is the mean arterial pressure table. This is pethidine consumption, post-operative complications. In the discussion, our results showed heart rate and mean arterial pressure. There existed a significant difference, which is lower in non-opioid group than opioid group, which is similar to Shelby et al. Study. In contrary to our study, Jan et al. Study showed there was no differences in heart rate and mean arterial pressure. Regarding oxygen saturation, no significant difference between two groups, which is similar to Mansour et al. Study. Regarding VAS score in this study, our study is similar to Shelby et al. Study, where they showed significant decrease at 0 hours post-operatively. Regarding total pethidine consumption, there was statistical significant difference between the two groups, which was lower in opioid-free anesthesia group, which was similar to Hunter et al. And Samuel et al. Studies. Regarding post-operative complications, significant difference between the two groups existed, which is similar to Jan et al. Study. In the conclusion, the study concluded that opioid-free anesthesia provides intraoperative hemodynamic stability and post-anesthesia without significant associated adverse effects when compared with opioid anesthesia group. These are my references, and thank you.
Dr. Lavanya, you were too fast. And
Sir, actually,
yeah, you had
sir,
to fit it into the time limit. I know that.
no, sir. Actually, my topic is on physiological changes in pregnancy. They have they have changed and somehow put my paper presentation.
Yeah, exactly. We were wondering why this.
This is my paper presentation, sir. Actually, I'm prepared for physiological changes, sir. Okay, sir. One more video is coming, sir. They'll start, it seems.
Because we were also not knowing why this case.
Yes, ma'am.
This is actually doesn't fit in the criteria of this session.
Actually, I'm supposed to present on physiological changes, ma'am. I have sent video. I don't know how to put
Just
paper.
hold on, Mr. Gurmeet. Just wait for a minute. Till
yes,
then, can we have the next presentation? She can again come back.
Yeah.
Yes, ma'am.
Lavanya, can you just wait for a while? He will adjust the presentation. Till then, we can have some.
Thank you.
Sorry for them.
Okay.
Presentation by Dr. Avni.
Avni, are you there?
Yeah, recorded.
My name is Dr. Avni Thakkar and my presentation topic is the cardiovascular responses to the intubation, laryngoscopy, endotracheal intubation and other airway inhalations are noxious stimuli that may induce profound changes in cardiovascular physiology, primarily through reflex responses. Responses may be of the shorter duration or a little in the healthy individual, but there may be serious complications can occur in patients with coronary artery disease, reactive airways, and intracranial neuropathology. Cardiovascular reflexes. It is initiated by the proprioceptor responding to the tissue irritation in the area. They are closely proximately located in the upper airway mucosa, and they are proprioceptor consists of mechanoreceptors with small diameter myelinated fibers, which are slowly adapting stretch receptors with large diameter myelinating fibers, and polymodal ending non-myelinated nerve fibers. From this, stimulus is passed to the glossopharyngeal and vagal afferent nerve, and this impulses from there transmit to the brainstem. From there, they transmit it to the widespread autonomic activation through the which sympathetic and parasympathetic nervous reacts. Bradycardia in infant and small children during laryngoscopy and intubation is the autonomic equivalent to the laryngospasm reflexes. This reflex results from the increase in vagal tone at the sinoatrianodal pathway, and it virtually a monosynaptic response to the noxious stimuli in the airway. This response is rare in adults. Adults and adolescents have more common responses to the aero manipulations, which are hypertension and tachycardia. This pathway is mediated by the cardio-oscillated nerves and sympathetic chain ganglia. And their responses by widespread release of norepinephrine from adrenergic nerve terminals and secretions of epinephrine from the adrenal medulla, which causes activation of the renin-angiotensin system, including of the renin from the renal juxtamedullary apparatus, and innervating by beta adrenergic nerve terminals. Activation of the autonomic nervous system, laryngoscopy, and endotracheal intubation may result in stimulation of the central nervous system, and as a evidence by increase in EEG activity and cerebral metabolic rate and cerebral metabolic blood flow. Patient with compromised intracranial compliance in the increase in the CVF may result in elevated intracranial pressures, which may result in herniation of the brain and serious neurological compromises. Intubation in patients of the cardiovascular diseases. The chief component on the demand side of the myocardial O2 balance equations are the beat frequency of the heart rate and myocardial wall tension. Among two, increase in the heart rate are the greatest concern because cardiac inotropism and subserves cardiac conotropism. Tachycardia increases myocardial O2 consumption per minute at constant wall tension, but elevation in the rate effectively reduces the diastolic period, and full diastolic relaxation may be impaired, and a subsequent increase in the resting wall tension will impair the subendocardial blood flow, reducing myocardial O2 supply, and the rate of the intraventricular pressure development, and the systole and measures of the myocardial contractility and other determinant of the myocardial O2 demand, which will also increase. Complications in the patient with cardiac disease or myocardial ischemia are chief among them. This set of circumstances is responsible of episodes of ischemic electrocardiographic ST segment depression, increased pulmonary blood pressure, and that may be seen when intubation is performed in patient with atherosclerosis. These episodes precede the occurrence of the perioperative myocardial infarction. Aortic circulation may also be particular risk of complication related to the sudden increase in BP and airway instrumentation. Laplace law defines that the transmural wall tension of the blood vessel, which may determine the likelihood rupture of the product of the pressure inside the vessel, and its radius is divided by the wall thickness. The presence of the thin wall vascular aneurysm combined with a sudden increase in can lead to rupture and affected blood vessel and abrupt deterioration in the patient's status. Leaking aortic aneurysm are partially tamponed by intra-abdominal pressure, but can suddenly expand into the retroperitoneal spaces during the arterial hypertension. Intubation in patient with the neurovascular diseases. Intracranial aneurysm and atriovenous malformations often arises with a small sentinel hemorrhages during subsequent period of elevated BP. These lesions are likely to be deep-bleed, resulting in sudden permanent neurological injury. Patients present for anesthesia at the time when the clot or tamponading the aneurysm or AVM is particularly delicate, and a small increase in arterial transmural pressure could cause re-rupture. One of the times which in this it is most likely to occur that when arterial BP and heart rate are increased, response to the endotracheal intubation. Responses to the endotracheal intubations are also potentially hazardous to patients with compromised intracranial compliance, resulting from the neuropathologic processes such as intracranial mass, lesion, brain edema, or acute hydrocephalus. Uncontrolled coughing can result in intrathoracic and intra-abdominal pressure that may in turn increase in the cerebrospinal fluid pressure, which may result in impairment of the cerebral perfusion. In patients with the impaired cerebral autoregulation, cerebrovascular accident, neoplasm, the normal tendency of the CBF to remain constant over the mean of BP range from 50 to 150 mmHg is impaired, and when endotracheal intubation causes an increase in arterial BP, there is marked increase in CBF and cerebral blood volume, which may in turn cause dangerous increase in ICP. Thank you.
Dr. Niru?
Yeah, I would just like to say that the content on the slide should be much less. This was too much on one slide to be shown. Around 10 to 15 sentences is not readable on a slide. It was a nice presentation, although slowly presented.
Thank you, ma'am.
Avni, how can you attenuate these responses?
Ma'am, to attenuate these responses, we should spray lignocaine spray on the upper airway surfaces on pharynx, or we can give IV lignocaine and we can give IV dexmedetomidine, IV fentanyl, or IV beta blockers to attenuate these responses, ma'am.
Avni, can you just tell us the pathway for this reflex? There's a response pathway. Huh?
Hello.
Can you hear the question? Can you describe
No,
us
sir,
the pathway? Can you describe us the pathway for this response?
Yes, sir, from the upper airway surfaces, the receptors which are slow myelinated and largely myelinated fibers, from there noxious stimuli transfer to the glossopharyngeal and vagus afferent. From this pathway, it transmits to the brainstem, and from brainstem, it activates the autonomic system like parasympathetic and sympathetic stimulations for this noxious stimuli.
Thank you, Avni. Can we
Thank you,
have
ma'am.
Dr. Rafia Khan?
Good morning, everyone. I'm Dr. Rafia Khan from ESI Hospital, New Delhi. The topic of my today's presentation is comparative evaluation of time for orotracheal intubation using non-handle mounted radiolaryngoscope versus handle mounted radiolaryngoscope in patients undergoing elective surgeries. As you all know that airway management is one of in the field of anesthesiology, and endotracheal intubation with the help of Macintosh laryngoscope has always been a gold standard for definitive airway management. In recent years, videolaryngoscopes have gained in popularity, and in our study we have used one handle mounted videolaryngoscope, that is CMAC videolaryngoscope, and handle mounted videolaryngoscope. These are the two videolaryngoscopes we have used in our study. After carefully searching recent literature on the online sources, we did not find any published study comparing non-handle mounted videolaryngoscope and handle mounted videolaryngoscope in India, although similar studies have been conducted around the world. Currently, there is a lack of clinical research contrasting various videolaryngoscopes in India, so the present study was conducted in adult Indian population for the comparison of the two videolaryngoscopes. Our study aimed to find out if there was any difference in time taken for orotracheal intubation between the two videolaryngoscopes and used in patients undergoing general anesthesia. CMAC videolaryngoscope consists of three basic parts, namely laryngoscope, an electronic module, and a separate 7-inch monitor. It also consists of a lithium-ion battery with a built-in 2-hour power capacity. It has reusable metal Macintosh blades ranging from size 2 to 4, in addition to a D blade for difficult airway in adult patients. It has slim blades and slanted edges to avoid tissue damage. The contact area of the blade of this videolaryngoscope is significantly low as compared to the classic Macintosh blade, and this helps in making more space for lifting up the epiglottis. This is a CMAC videolaryngoscope. Mid-cap videolaryngoscope consists of 2.5 inches LCD screen attached to a portable handle. It contains a light source with a small camera present at the tip of the blade, which is powered by a battery within the handle, and therefore it works as a portable unit, and separate power source and cables are not required. It contains transparent, sterile, single-use blades ranging from sizes 2 to 4 and a Megarat X blade for use in difficult airways. This is a Megarat videolaryngoscope. The research study was conducted in the Department of Anesthesiology, ASI Hospital, New Delhi. After the approval of ethical committee of the institution, a total of 60 patients were enrolled for the study, and informed consent was obtained from all patients. It's a prospective randomized study. We divided the patient into two groups, Group CM and Group MG. Each group consisted of 30 patients. Group CM, where orotracheal intubation was done with the help of CMAC videolaryngoscope, and Group MG, where orotracheal intubation was done with the help of Megarat videolaryngoscope. We included the patients who had ASA grade 1 and 2, aged between 18 to 60.
Good morning, respected judges. A wrong video has been played for my
That is why there is interruption. We have interrupted and they're going to play the second one. Sorry for the inconvenience.
No, it's okay.
Dr. Rafia?
Yes, ma'am.
What was the hypothesis behind this study? This is a nice study, I think.
Ma'am,
What made you think to do this comparison?
Ma'am, actually, we have both the video laryngoscopes in our department for past 6-7 years. But we've compared these video laryngoscopes with the conventional ones in all our previous studies. But this one we thought of comparing two video laryngoscopes instead of comparing it with the conventional one. So our hypothesis was basically we hypothesized that there was no difference in time taken to intubate between the two. We considered that both will take the same time and there'll be no difference. But actually, at the end, we got a significant difference.
Okay, it is just a difference of a vision. Kitna wo far placed hai, that is all, I think. Huh?
No, ma'am. There's more. There's more.
Okay, chal.
Yes, ma'am.
They found the video, Rafia. Just few seconds.
Yes, sir. Yeah.
Good morning, everyone. I'm Dr. Rafia Khan from ASI Hospital, New Delhi. The topic of my today's presentation is anaphylaxis in the perioperative period. The term coined by Nobel Prize recipient Portia and Richard in 1902. It is defined as any acute onset of illness with typical skin features, that is urticarial rash, erythema, flushing, or angioedema, plus involvement of respiratory and/or cardiovascular and/or persistent severe GI symptoms or CNS symptoms. The operation theatre is a unique clinical environment because the patients are exposed to numerous medications over a relatively short period of time, particularly during induction of general anesthesia. Patients are also exposed to numerous non-drug substances such as antiseptic skin preparations, intravenous colloids, and latex. As a consequence, anesthesiologists are more likely than most other physicians to witness and manage allergic reactions. The incidence of anaphylaxis during anesthesia has been reported to range from 1 in 4,000 to 1 in 25,000. Amongst the drugs which are associated with anaphylaxis in the perioperative period, the common ones include neuromuscular blocking agents. Other common triggers include antibiotics, natural rubber latex, colloids, general anesthetic drugs including propofol, thiopentone, opioids including morphine, sedatives including midazolam, local anesthetic drugs, dyes, and Stirling gases. gel. And Coombs have classified hypersensitivity reaction into 4 types. Type 1, which is immediate reaction and IgE mediated. Type 2, which is cytotoxic and complementary mediated. Type 3, which is immune complex mediated. 4, which is delayed and cell mediated type of reaction. IgE mediated reaction of anaphylaxis occurs when antigen processing cell, that is macrophage, get exposed to the allergen, which further alerts the body to the foreign allergen. In response, the body produces allergen specific IgE antibody, and this antibody binds to its receptor in the mast. Now, when the re-exposure occurs and a subsequent antigen binds to a already existing IgE mast cell or IgE basophil complex, degranulation results, and the preform mediators like histamine, leukotriene, prostaglandin, and tryptase are released into the blood. All these mediators are responsible for the increase in blood flow and leakage of protein and fluid into the tissue spaces and setting up of inflammation. All of them work together to produce clinical manifestations of edema, rash, pruritus, vascular compromise, and respiratory difficulties seen in anaphylaxis. Severity of anaphylaxis can be graded into 4 grades. Grade 1, which is mild and manifested by mucocutaneous signs only. Grade 2, which is moderate and manifested by mucocutaneous signs combined with hypotension and or bronchospasm. Grade 3, which is characterized by life-threatening hypotension and or high airway pressures. Oxygenation and ventilation are rapidly compromised here. Grade 4, which is a more severe form of anaphylaxis and manifests as cardiac arrest. Amongst the common signs and symptoms of anaphylaxis are urticaria and angioedema, flushing, pruritus, dyspnea, wheezing, upper area angioedema, dizziness, syncope, hypotension, nausea, vomiting, and diarrhea. Manifestations of anaphylaxis in the perioperative settings are observed as difficulty to intubation, post-extubation stridor, respiratory pressure, increase EtCO2, decrease oxygen saturation, cardiovascular collapse, arrhythmia, cardiac arrest. Skin manifestations may be absent or if present may be hidden by the surgical drapes. Initial diagnosis can be made by history and physical examination. Retrospective diagnosis can be made by serologic and skin tests. Serum tryptase, which can be measured in the serum 30 minutes after the first sign of anaphylaxis. In vitro tests include radioallergosorbent test, which is a highly specific test. In vivo tests include skin prick tests and intradermal tests, which are used for testing sensitivity to local anesthetic, muscle relaxant, and propofol. When anaphylaxis has set in, immediate management should be started. Call for help immediately. Check for airway, breathing, and circulation. Stop administration of all drugs, colloid, and blood products. Inform the surgeon. Consider waking up the patient. Maintain airway with 100% oxygen. Secure large bore IV cannula. Patient should be returned to supine position as soon as possible, where continued resuscitative efforts are required. Fluid resuscitation is a critical step in the management of hypotension because almost 35 to 70% of the blood volume may extravasate in 10 to 15 minutes. And so, repeated fluid boluses of 20 ml per kg may be required. In case of cardiac arrest, good quality CPR should commence. IV adrenaline 1 mg every 3 to 5 minutes can be given. Adrenaline is the first line of treatment for anaphylaxis because it causes vasoconstriction and bronchodilation, increased cardiac output, reduced mucosal edema, and reduced mediator release. Therefore, adrenaline not only treats signs and symptoms, but also reduces response amplification. It can be given via intravenous route or intramuscular route. Intravenous infusion of adrenaline is also started. Second-line medications include antihistaminic drugs, which prevent additional release of histamine and may be used to treat cutaneous manifestation of anaphylaxis. Corticosteroids may also be treated as second-line agent because they reduce inflammation. These medications take 4 to 6 hours to have, not used as first-line agents. In case of resistant hypotension, consider alternate vasopressors like noradrenaline and vasopressin. Also consider cardiac bypass and ECMO for re-establishing adequate perfusion. Resistant bronchospasm can consider inhaled bronchodilators like salbutamol. Also consider salbutamol, intravenous magnesium, and nebulization with epinephrine. In the post-crisis management, observe for at least 6 hours after a grade 1 and grade 2 reaction, and after a grade 3 and a grade 4 reaction, observe the patient in ICU and HDU. Perioperative anaphylaxis can be prevented by taking a careful history regarding adverse drug reaction and allergies and identification of at-risk patient. I would like to summarize by saying that muscle relaxants are the most common anesthetic drugs that may lead to anaphylaxis. Although anaphylaxis is a rare intraoperative event, but most drugs used in the perioperative can lead to anaphylaxis, and hence documentation of anaphylaxis during anesthesia is a very important process. These are my references for the session. Thank you so much for patiently listening to me.
Dr. Neeru?
Yeah, Dr. Rafia, Any specific group of patients who are more prone to anaphylaxis?
Ma'am, particularly children and elderly, extremes of ages, because the metabolism of the drugs is different from the normal adult in both the groups of patients.
And on the basis of gender?
Ma'am, female preponderance is given in the literature.
Nice presentation.
Thank you so much, ma'am.
Rafia, very good presentation. Do you have any experience regarding anaphylaxis in any of your cases?
Yes, ma'am, we had in our ICU to blood product. The patient immediately developed erythema and rashes all over the body. But we recognized it, and we before any such it could have turned into a grade 3, but we recognized at initial stages, so we managed it. But particularly to any group of drugs or to colloid, or I have not seen as such.
Okay, thank you.
Thank you.
Dr. Sukanya, please, can we have a presentation?
A very good day to one and all. Today I'm here to speak on the theories of anesthesia. So it is very interesting to note that just after 6 months after ITER demonstration, the very first anesthetic theory was formulated, which stated that the general anesthetics act by eluting fat from the brain. But there was no clinical basis for this, so this theory was rejected. The next theory which came into light was the Bernard's unified theory, which stated that the susceptibility to anesthesia defines life. So he conducted a series of experiments on plants and on rodents, exposing them to ether and stating that the principle of irritability was abolished on exposure to ether. So this helped to differentiate between living and non-living components, its susceptibility to anesthesia. The very first widely accepted theory was the Mayer-Overton theory, which stated that the potency of an anesthetic agent is proportional to its lipid solubility. So here we have the concept of the partition coefficient, which is the solubility in fat by solubility in water. So greater the partition coefficient of an anesthetic, greater would be its potency, but it had its own disadvantages. So here, as we see, the stereoisomers, that is the R isomer of intermediate, is 10 times more potent than the S isomer, even though both of them have the same partition coefficient. And also, most of the lipid-soluble molecules, many of them were actually convulsants and they had no anesthetic action at all. And greater the size of the anesthetic side chain, it had to have more potency. But actually, we observed a cutoff in the potency of local anesthetic of the anesthetics beyond increase in side chain. So, because of all these disadvantages, this theory also could not be widely accepted. And next, we have the Miller's theory, which stated that the anesthetic molecules orient microcrystals around them, forming an iceberg, blocking the membrane pores, decreasing the electrical conductance, and bringing about the anesthetic effect. So, but none of this were able to actually explain how the anesthesia happened. So, the nature of the quest changed from that is the target was in the lipid membrane, to how the process of anesthesia. So here we have various mechanisms of theory, such as the binding site theory, the cellular theory, and the circuit and network theory, which explain how the anesthetic action was brought about. So moving on to the receptor binding site theory, these are actually membrane proteins, so which activate certain ion channels and bring about the anesthetic effect. So here we have certain ligand-gated ion channels, such as neurotransmitter-gated, such as GABA, glycine, and NMDA glutamate receptors. The benzodiazepines bring about effect by increasing the frequency of the GABA channel opening, and barbiturates increase the duration of the GABA channel conductance. So by modulating these ion channels, they bring about the anesthetic effect. And next, we have the voltage-gated ion channels, such as sodium, calcium, and the 2-pore potassium channel, which is a TREC channel. Mainly volatile anesthetics and propofol act through these channels. So when they bind to the lipid membrane to cause a disruption in the membrane, which leads to a translocation of the phospholipase, which is in the membrane, and opens these ion channels, modulating their conductance. And also certain side effects of anesthetics, volatile anesthetics, such as malignant hyperthermia and arrhythmogenic effects, can also be explained by this voltage-gated ion channels mechanism. Next, moving on to the cellular mechanism, this was mainly the presynaptic and the postsynaptic effects. of anesthetics. So it increases the inhibitory and inhibits the excitatory synaptic transmission. Also, research was found out by research that in hippocampus, the tonic current inhibition led to the amnesia, that is the memory loss during anesthesia. And next, moving on to the circuits and the networks theory. Here, the synaptic plasticity or the long-term potentiation is being blocked by the volatile anesthetics and ketamine, bringing about the memory loss or the amnesia seen during anesthesia. Also, alpha delta EEG changes, such as the alpha delta phase changes, is the signature of propofol, and theta and gamma rhythms are the signature of the volatile anesthetics. And the various components of anesthesia, that is immobility, can be explained by the membrane site theory, and amnesia can be explained by the network theory, and the unconsciousness can also be explained by the circuits and the network theory, and also the sedation, which is brought about in anesthesia, can again be explained by receptor-mediated theory. Also, certain recent advances, that is genetic recombinases, have been identified in the lateral habenula thalamic nucleus, which is responsible for the sedative effects of propofol. Also, PET scanning has shown that memory suppressive episodes of propofol are mainly due to its prefrontal and parietal cortex action. And also, susceptibility to isoflurane has been localized to the chromosome 7. So there is no single theory that has been found to bring about anesthetic action. It is a combination of all these theories that actually brings about the anesthetic action. And with that, I would like to conclude my presentation. Thank you.
Thank you, Sukanya. Nicely presented. So how do you apply the clinical this presentation in your clinical practice? That is more important. We know the theory now. You have explained the theory. How do you apply it in your routine clinical practice?
Yeah, good morning, sir. Thank you, sir. Sir, these theories of anesthesia, they have a theoretical, they only have a theoretical basis, sir. Like there is no single theory which has been explained to bring about the exact anesthetic action, sir. So, like we have to see the effects on the patient based on whatever effects that this anesthesia has. Based on that, we can have the choice of drugs, sir, for each case.
Madam Luthra, madam.
Like in sir, in voltage gated ion channels like calcium channels, sir, like some effects of malignant hyperthermia has been explained through that, sir. Like in certain mutated ryanodin receptor channel patients, this volatile anesthetic action, it increases this calcium is being excess of calcium is being pumped from the sarcoplasmic reticulum, and its level decreases. So this can lead to a hypermetabolic state. So it has some practical value also, sir. And some genetic basis, that is the hereditary ether channels, they have been found, the abolishing of such channels has been by halothane has been found to explain the arrhythmogenic effects of certain volatile anesthetics.
Yeah. Luthra, madam.
Nice presentation, Sukanya. No questions.
Yes.
Thank you, Sukanya.
Thank you, ma'am.
Can we have Dr. Lavanya's presentation?
Dr.
Lavanya's presentation.
Good afternoon to one and all. Myself, Dr. Lavanya, and I am going to discuss on the physiological changes in pregnancy and its major implications for anesthesia. Pregnancy produces profound physiological changes that become more significant. These changes can be due to hormonal alteration, mechanical effects of gravid uterus, increased oxygen and metabolic requirement, hemodynamical alteration. It is a unique challenge to patients. Volume homeostasis, fluid retention is the most fundamental systemic change. The plasma volume increased is during a pregnancy is 45%. Factors contributing are increase in sodium retention, decrease in thirst threshold, decrease in plasma oncotic pressure. Cardiac output effects, cardiac output about 40% increases. This increases more stroke volume and heart rate. Cardiac output increases about 40% by 12 weeks, 50% for rest of pregnancy, 60% to 100% during labor and after delivery. Cardiac output is highest right after delivery due to release of high torque caval compression. Cardiovascular effects. Peripheral vascular resistance decreases due to vasodilator effects of progesterone. Because of decrease in peripheral vascular resistance, there may be a slight fall in BP. Diastolic will be more than the systolic. The response to adrenergic agents and vasoconstrictors is blunted. These are the parameters which change during pregnancy. This is the investigations. Its anesthetic implications on CVSR, compression of lower aorta would lead to fetal hypoxia. Compression of IVC would lead to supine hypotension syndrome, hypotension associated with pallor, sweating, nausea, and vomiting. Decrease in cardiac output can occur after 28 weeks of pregnancy. Women with 28 weeks or longer should not be placed supine without left uterine displacement. It is done by left lateral eucalyptus, tilting the table left side down, rigid wedge more than 15 degrees under right hip, fluid preloading. Physical examination should be, women may also be abnormal with auscultation. Respiratory changes. Changes in respiratory system during pregnancy involve upper airways, minute ventilation, lung volumes, and oxygen consumption. Dyspnea is a common complaint. Pregnant women takes larger tidal volumes. These are the respiratory parameters which change. Diaphragm rises up about 4 centimeters. Compensatory increase in AP diameter. Diaphragm motion is not restricted. Thoracic breathing is favored over abdomen. Decrease in FRC to CC plus increased oxygen consumption would lead to rapid development of hypoxia. So pre-oxygenation should be given prior to induction of general. Hormonal changes, capillary engorgement of respiratory tract mucosa would lead to increased incidence of difficulty intubation, trauma, and bleeding. So use a smaller size endotracheal tube and repeated attempts at laryngoscopy should be minimum. CNS changes are progressive decrease in minimal alveoli concentration, about 40% at term. Progesterone increases about 20 times normal levels. Fetal endocrine surge during labor and delivery. Its anesthetic implications are local anesthetic requirements for subarachnoid or epidural are reduced in pregnancy due to increased diffusion of local anesthetic to receptor site and increased sensitivity of nerve fibers to local anesthetic. And there will be engorged epidural venous fluxes. IVC obstruction by enlarging uterus would lead to engorged epidural venous plexus, leading to decreased CSF volume, decreased volume of epidural space, and increased epidural space pressure. GIT changes, the parturient should be considered a full stomach. Upward and anterior displacement of stomach by the uterus and incompetence of gastroesophageal sphincter would lead to gastroesophageal reflux and aspiration. Increased progesterone would decrease the tone of gastroesophageal sphincter. Gastric emptying is delayed with labor. Narcotics and anticholinergics should be used with caution. For every general anesthesia in pregnancy, pharmacological prophylaxis against aspiration, supine position with lateral teeth, no positive pressure ventilation should be given. Rapid sequence induction and Selix maneuver should be followed. Renal changes are renal vasodilation increases leading to increased GFR and renal plasma flow. Hepatic effects, hepatic function and blood flow are unchanged. There may be a mild decrease in serum albumin. Hematological changes increase blood volume up to 90 ml per kg. It increases by 1000 to 1500 ml at term. Increased plasma volume about 45% and increased RBC mass about 30%. Dilutional anemia, decreased blood risk. Hypercoagulable state, pregnancy would lead to increased risk of thromboembolic disease. So post anesthesia. Other changes are leukocytosis, increased DSR, 10 to 20% decrease in platelet count and decreased cell-mediated immunity. Pregnancy is a diabetogenic state. Placental lactogen would cause relative insulin resistance. Musculoskeletal changes are increased level of relaxin and increased risk of back pain. Thank you.
Dr. Luthra, madam, your questions.
Dr. Lavanya,
good
what do the
morning.
guidelines of AHA say regarding resuscitation of a full-term pregnant patient who has a cardiac arrest?
What, ma'am? Can you repeat one more time, ma'am? Question.
AHA guidelines for resuscitation of a pregnant patient, a full-term pregnant patient. Resuscitation.
For cardiac arrest, madam?
Yeah. In a full-term pregnant patient.
We should do like CPR, madam?
Yeah. It is a bit of deviation of the question from your topic, but it is relevant to this pregnant patient.
Yeah, madam. We should immediately do cardiopulmonary resuscitation for cardiac arrest cases.
Okay.
And immediately do the delivery, madam, in this case.
What is CABU? CABU?
CABU.
C is for circulation, A is for airway, B is for breathing, and U is for uterine displacement.
Okay.
What is perimortem cesarean section?
At least let us know the time.
At least let us know the time.
The time limit.
Time limit.
Within 3 minutes, we should deliver the.
Sure.
Okay.
Very
Thank you.
good. Okay.
This is the end of the session. I think is there Gurmeet, is there any other? So I thank all the speakers who have participated, and shortly we'll make the list of the marks. Luthra madam, and we all are here.
So I just wanted to ask, we had 9 presentations today, in case I missed out something.
No, we have 10 together. 1, 2, 3, 4, 5. Namrata, Nehali, Nivedita, Prerna, Raghav, Saras Singh, Lavanya. Lavanya
Yes.
was at the last. Avni,
Yes, ma'am.
Rafia, and Sukanya.
Yeah. Surekha also, some name was written. It was not presented by Surekha, no? There was no Surekha today. And this makes it 9, I think. 1, 2, 3, 4. Yeah, 10. Okay, thank you, ma'am. Thank you.
Yeah, it's okay. Neeru, would you like to end the session?
It was nice being a judge in this ISACON 2021. I was the judge for the first time for this session, I think. Thank you so much. It was a pleasure being with you. Thank you so much.
All the participants who participated in the session, and all the presentations were very good. Thanks a lot.
Let's move to the next session. Geriatric challenges in anesthesia. The chair is Dr. Depashri and Dr. Rima Madhwa. Dr. Depashri, over to you.
Yes. It's good afternoon to all of you. At the outset, I would like to thank ISACON 2021 for inviting me to chair this session. Now we'll move on to geriatric anesthesia session. The first topic is physiological changes of aging, and the speaker is Dr. Surekha S. Chavan. Yes. So I'd like to introduce her. She is Senior Associate Professor, BJ Government Medical College Hospital, Pune, Maharashtra. She has 23 years of teaching experience, PG guide and examiner, clinical experience in dental, ENT, obstetrics, neuro, and geriatric anesthesia. She was Secretary, Geriatric Society of India, Pune chapter, Governing Council member, Respiratory Society, BJGMC, Pune, organization of 15th International Conference on Geriatric and Gerontology, IISER, Pune, 2018, base paper PhD, 4th World Congress on Geriatric and Gerontology, 2016, first rank holder, PGDGM and BJGMC Pune 2016, 10th International and 20 national publication, faculty and international, national, state and journal conferences. PhD scholar Kim's Award. So I'd like to invite the speaker for delivering the lecture.
Should I start? Good morning, everybody. Thank you, madam, for nice introduction. My topic is physiological changes of aging. Let us know what is aging is a process of growing old, and elderly are having chronological age more than 65 years. So worldwide in 1990, there were 0.5 billion elders, which are expected to rise to 2 billions in 2050, and in 21st century, there will be 3 billion around. In India, the population is supposed to expected to rise from 8% to the 19% in 2050, and it will be 34% to be expected in 21st century. So there will be overall 4% rise in surgical illnesses in elders. So 25% of operation theater population will be elders. So we should know about the basics of geriatrics. So central nervous system changes. There is overall decrease in brain mass, gray matter, and hippocampus and subcortical white matter. All these are having the cognition relevance. There is increase in ventricular blood flow, metabolic rate, and electrical activity remains unchanged. The receptors are decreased, but glutamate remains unchanged. There are decreased nerve root fiber, Schwann cells, distance, and this leads to increase in conduction velocity and increased block sensitivity. There is decreased epidural space and CSF and increased dural permeability. So this leads to increased sensitivity to local anesthetic drugs also. So changes in cardiovascular system are basically due to vascular aging. It starts with arterial stiffening due to loss of elasticity, and then the reflected pressure from increased pressure in aortic root during late systole. This leads to ventricular hypertrophy and impaired diastolic feeling. So decreased venous compliance is also there due to veins also stiffen like arteries with age, and the stiff veins are less able to buffer the changes in blood volume. They are having less effective reservoir of blood, and they are more sensitive to hypovolemia. The volume shifts cause exaggerated changes in cardiac filling pressure. So fluid management should be very precaution in elderly. There are vascular changes in elderly are due to breakdown of elastin, collagen, and alterations in nitric oxide induced vasodilation that causes elevated mean arterial pressure and pulse pressure, and also decreased venous ventricular compliance and afterload increase leads to decreased early diastolic filling time. So cardiac rhythm other than sinus rhythm is very poorly tolerated in elderly. There is also cardiac muscle cell death, and these cells do not divide in adequate numbers in adulthood. Remaining cells hypertrophy to compensate, which is another cause for ventricular hypertrophy. So there are also reduced synodal cells with fibrotic infiltration of conducting system. The ventricular contraction slows with the aging, and ventricles may not be fully relaxed during beginning of diastolic filling phase due to myocardial fibrosis. The result is early diastolic filling is impaired, and the preload depends on atrial kick. So these consequences of delayed relaxations are that tachycardia and atrial fibrillation are not well tolerated in elderly, and there is narrow range between the inadequate filling pressure and fluid overload. So they are preload sensitive. The diastolic dysfunction is the most common cause for heart failure in elders. Autonomic changes are decreased beta responsiveness and increased sympathetic tone, and that makes that preload reserve remains most important to meet the increased peripheral blood flow demand in elders. The hemodynamic response to the anesthesia is they remove the sympathetic tone. Dramatic changes can be seen when baseline tone is very high. It directly can depress the heart and vascular smooth muscles and decrease beta responsiveness. The changes in sympathetic tone also depends on surgical stimulus and variability of depth of cardiac adjustments are overall due to arterial steepening during aging, and cardiac response to increase the increased flow demand in elderly is all due to the changes. And finally, it depends on a preload reserve, and they are more susceptible to the cardiac failure. Changes in the respiratory system are increased rigidity of thoracic cage and kyphosis. There is loss of height and calcification of vertebral column, and that causes barrel chest appearance. So increase epidiameter, and with diaphragmatic flattening, it makes diaphragm less impaired. Again, it is due to loss of muscle mass, and overall this leads to decreased chest wall compliance and increased work of breathing. There is also decreased lung expansion and blunted cough reflex and reduced ciliary function, though are prone for pneumonia. But as in young, there are typical signs and symptoms of pneumonia. The elders are having atypical signs and symptoms, so where high index of suspicion is needed. The lung volumes, there is decrease in vital capacity due to decreased thoracic elasticity and muscle power. The residual volume is increased. Increase in functional residual capacity, increase in dead space, and increase in closing capacity. Decrease in diffusing capacity is also noted. The flow routes are changed due to loss of muscles and associated with weakening. There are limited MEFR response to exercise and reduced FEV1 and reduced FEV1 FRC ratio. Also, blunting of hypoxic pulmonary vasoconstriction reflex is seen, and there is a raised pulmonary arterial pressure, and PVR is raised by 80%. So decreased efficiency of gas exchange is seen in elders due to breakdown of elastin connections between connective tissue and alveolar tissue, poor tethering of lung tissue to airways, and they are prone for atelectasis, that is having a risk of hypoxia and pneumonia in elders. Smaller airways are more prone to collapse and increases the shunting and dead space. So all these structural changes that I summarized, that ultimately leads to increase in anatomical dead space, decrease in diffusing capacity, and increased closing capacity. So these pulmonary changes are again increase in pulmonary pressure due to increased lung compliance, increase in lung compliance and steep thorax, decrease in height and vertebral calcification, diaphragm flattening. So it leads to high work of breathing, and they are having risk of hypercarbia. Decrease in the CNS responsiveness is there due to blunted response to hypoxia and hypercarbia. So remember, elders are prone to airway collapse with risk of pneumonia. They can have lower blood oxygen levels with greater need for supplemental oxygen. Hypoxia is more likely due to the residual CNS effects. So geriatrics have risk of respiratory failure commonly in postoperative settings, necessitating postoperative intensive care management sometimes. Changes in the GIT are the decrease in strength of muscles of mastication, taste, and thirst. All this leads to poor nutrition and hydration, makes the physiological changes. Also, esophagus is having praised by esophagus changes in motility, and there is decrease in peristaltic movement and delayed transit time, leading to the dysphagia. There is relaxed lower sphincter leading to aspiration. So they are prone to aspiration and also due to GERD. The stomach problems are should be kept gastritis and heartburn. They are making them for having polyphagy and polypathy. So drug interactions should be kept in mind with the geriatrics. The colon, there is decreased motility that leads to constipation and increased storage capacity. So they may be on laxatives and polypathies, so drug interactions. In hepatobiliary system, liver mass and blood flow is decreased, but LFTs are conserved. Catalytic enzyme activity is decreased. Synthesis of protein binding and coagulation factors is decreased. Drug metabolism is low, and they are prone for biliary tract surgical illnesses. So anesthesia exposure is there in geriatrics for this cause. In genitourinary system, bladder capacity decrease and there is less sensation. So they are prone to have overflow incontinence, and they can have UTIs incidences, which is commonly around 20%. Same for prostate enlargement in 90% of the males, but 10% are symptomatic and they become a surgical candidate with associated many comorbidities. The uterus, commonly DUB and prolapse are there, making the issues are anemia and bladder bowel issues, making them coming for a commonly surgeries of uterus. The renal changes are gradual decrease in volume and weight of kidneys, decreased renal blood flow as due to reduced cardiac output and thickening of arteries. There is decrease in total glomeruli, leading to age-related decrease in creatinine clearance. But creatinine is a poor indicator due to the decrease in muscle mass in elders. Age-related increase in blood urea nitrogen is also seen. Glomerulosclerosis is there that leads to decreased GFR, generally 10% decrease per decade. And also there is decreased the clearance. Musculoskeletal system, there are degenerative. They are on many medications, so polypharmacy and drug interaction should be kept in mind. But the pain is also very responsive, severe in elders, and remains the most common cause for POD to manage in a perioperative zone. Weight loss, there is decreased muscle mass, and that leads to decreased peripheral drug metabolism. The weight loss also leads to low BMR. Adipose tissues are increased, that alters the pharmacokinetics. Edentulism as such is having the problems of holding the mask, ventilation, scopies, and intubations and trauma, but their physiology is altered, so changes become exaggerated. Also, there is inability to chew and poor oral health. They can become candidates for surgical causes in elders, very common, and poor nutrition and everything has to be kept in mind in this patient. Osteoporosis, osteoarthritis generally leads to very commonly silent fractures or drugs. There can be on polypharmacies, and so drug interactions, positioning is difficult. That will be talked in a next presentation. And difficult techniques in regional anesthesia. Again, skin turgor is lost due to loss of subcutaneous fat. So easy bruising and IV cap securing is a problem. This is the way. And electrolytes, they are having reduced sodium conservation capacity. They are prone for hyperkalemia, hyponatremia, hypocalcemia. There can be subclinical hypothyroidism, and glucose intolerance can be sometimes seen in elders. In temperature regulation, they are prone to hypothermia, and this hypothermia, this decreased thermogenesis leads to the shivering or increased metabolic demand, slow drug metabolism, increase in myocardial ischemia events, or there can be delayed recovery from anesthesia and impaired mental status in geriatrics. So warming is very important in elders. The hematological changes and immune system changes, there is decreased bone marrow production and spleen size, stem cells age, erythropoietin resistance is seen, and they are prone to anemia. Immunosenescence is also multifactorial in a geriatrics. In integumentary system, it's already known to everybody, fragile skin, elasticity decrease, and fat is decreased. They are prone for pressure ulcers and infections, and also it is due to dehydration, circulation, and nutrition changes. So extra care during positioning and padding is utmost, as like in pediatric, in geriatrics also. Weakened skin barrier there and prone for easy bruising. Proper venous access is a must. Airway consideration, there is a stimulus threshold for vocal cord is closure is increased with blunted cough reflex, laryngeal reflex, and pharyngeal reflexes. This weak gag reflex and loss of esophagogastric sphincter tone. So the elders are prone for increased risk of aspiration. This remains many times post-operative common cause of mortality in settings. Arthritic changes, again, the changes for trauma and the polypharmacy should be kept in mind. Difficult intubation here can be anticipated. The intubation, again, there can be a difficult and cervical arthritis should be kept in mind. Aortic extension, drugs, and pressure response has to be kept in mind during the intubation and scopy of the elders. The pharmacology is behind the scope of these changes, but basically is due to altered albumin, alpha-1 proteins, total body water content reduction, and body fat. All this leads to the altered pharmacology. Renal and liver functions are also altered. So small doses should be preferred, and prolonged action should be anticipated in elders. So again, little about like inhalational MAC is decreased 6%, depends on volume of distribution, and so isoflurane is most likely to have a prolonged action, but sevoflurane, desflurane can have a better. Opioids, again, more potency, so dose requirement should be reduced, and the remifentanil is more potent in geriatrics. Same about the neuromuscular blocking drugs. If they are dependent on metabolism for renal and hepatic, should be dosage should be wisely selected. And peripheral nerve blocks, age is a major factor in determining the duration of motor and sensory blocks. So during managing these elders, optimization of comorbidities, aspiration prophylaxis, pre-oxygenation, fluid management, and hypothermia prevention and positioning care and monitoring are the mainstay for the precision. And post-operatively, you should be watchful for post-operative cognitive disorders like delirium, POCD, and dementia. And all this very important because there is impairment in the activities of daily living, where in this era of current generation, the elders are really facing their single stay at the home, having kids migrated or kids migrated for the foreign states due to their job profiles. And so their independence has to be preserved, and anesthesia should not contribute to the loss of their ADLs. Also, chances of hypothermia, UTI, pneumonias, ulcers should be seen, and PSU cause for admission has to be suspicious. Prevention of falls and frailty remains the falls should be in a mind, and frailty in a geriatric should be very wisely managed. And one should be knowing about the geriatric giants causes. So remember, the senior citizens are valuable because of silver, gold, stones, leads, and gas. So we have to be very precise in their management to achieve the perfection. So how to do that? It's by proper preoperative evaluation. Always assume diastolic dysfunction. Look for renal or hepatic dysfunction. Achieve the glucose control. Titrate the anesthetic drugs. Always go slow, but you can give always more. And vigilant intraoperative monitoring, positioning care, pain care, delirium management, and PCU care should be given whenever indicated. So, and again, this becomes mainstay that training of residents, paramedics, nurses, and caregivers has to be given to get a perfection in the management of the elders. These are the references. Thank you very much for kind listening.
Dr. Bhattacharya, you are muted. Unmute yourself. Dr. Bhattacharya, please unmute.
Okay.
Yes, ma'am.
Thank you very much for this nice deliberation. We'll discuss at the end of the session. Okay.
Thank you, ma'am. Thank you so
one
much.
More chairperson have joined us.
Yes.
Dr. Bharati BM.
It was a nice session, ma'am.
Yes.
So now the next talk is on orthotic and positional issue with geriatric patient by Dr. Surekha Shinde.
Yes. Yes. Am I audible? Yes.
Greetings from Dr.
Yes.
You are audible, ma'am.
So this is orthotopic and positional issues with geriatric patient. The speaker is Dr. Surekha Shinde, Professor Anesthesia, BJJMC Hospital, Pune. Ma'am, please just start your deliberation. Before that, I'd like to introduce you. Dr. Surekha Shinde is MD Anesthesiology from BJJMC Pune, FACE in Emergency Medicine, FAI MER Fellowship in Medical Education and Technology, PG Diploma in Medical Legal Systems, Symbiosis University, Certificate Course in Palliative Care from TCH Mumbai, more than 20 publications in indexed state, national, international journals, COPS Award for Best Paper in Neuroanesthesia, delivered presentation in state and national conferences, faculty in MATE, Emergency Medicine, examiners for DNB, COVID ICU in charge, expert in Pune Oxygen Committee, nodal officer for oxygen supply and management, member of ISA National Task Force for COVID-19, author of a book chapter on COVID management. Madam, please start your deliberation.
Greetings from Dr. Surekha Shinde, Professor and Head of the Department in Anesthesiology, BJGMC and ISACOON Hospitals, Pune, Maharashtra. At the outset, I would like to congratulate for this wonderful conference and I would like to thank them, the organizers of ISACOON-2021 Ahmedabad, for inviting me on the topic of orthotics and positional issues with geriatric patients. What are the prerequisites or requirements of ideal position during any surgery? It promotes proper physiological alignment. It gives minimum interference with circulation. It stabilizes and gives security in positioning. It protects the skeletal and neuromuscular structures. It gives optimum exposure to operative and anesthesiology site. It provides patient comfort and safety, and of course, maintains patient's dignity as well. What factors can contribute to the shortcomings in giving ideal position during surgery? Let's see. There are various factors. The nutritional status, especially frail patients, respiratory disorder, circulatory disease, obesity, chronic immobility, prescribed medications, underlying medical problems, the nature of the surgery, and of course, advanced age, as our topic is going to be. What are the different issues in difficult positioning in elderly age group? They have reduced physiological reserve. There is altered response to medications, especially pharmacodynamic and pharmacodynamic both as well. There is unpredictable response to interventions, both surgical as well as anesthesiologists. There are frequently medical problems, very multisystemic comorbidities, along with specific musculoskeletal disorders like osteoporosis, gout, pseudogout, or polymyalgia rheumatica. So positioning has to be balanced within the limitations set by the patient because of fixed or reduced mobility. What are the preoperative predictors for difficult positioning in geriatric age? First is increased osteoarthritis and rheumatoid arthritis with old age. There is progressive intervertebral disc degeneration of the spinal column with disc herniation and osteophyte formation. It can cause nerve root impingement and symptoms of spinal stenosis. Coming to anesthesia because of this, X-ray cervical spine is must for flexion and extension to decide the safest approach without causing neck injury or compromising spinal cord. Neuraxial blockade may be more difficult in elderly, which we will touch upon in few slides. The second reason is limited or almost joint mobility. The stiff joints, particularly in the cervical spine, hips and shoulder, and prevent optimal positioning. There could be limited neck mobility, leading to difficult airway management in general anesthesia. In supine position, reduction in elbow extension may cause difficulty to place patient's arm flat by their sides or out on the arm boards, which can be very irritating or disturbing to the patient in the awake condition. The third reason is fragile skin. Geriatric patients have fragile skin and decreased peripheral circulation. It increases the risk of nerve, joint, and skin injury due to this. There could be burns from improperly placed cautery pads. So we have to be very cautious during this. So oversight during initial patient positioning and neglect during intraoperative shifting can cause increased patient pain and infection risk. So during positioning a patient, extra care should be taken to avoid skin tears and bruising and apply extra padding on areas at risk of pressure ulcers, including sacrum and heels. We'll be discussing in a few minutes. Avoid adhesive tips, which is a very common entity in operation theatre using tips. So sticking is totally no. Avoid dragging the patient across the table and never ever pull sheets out under patient. The fourth reason being age-related vertebrobasilar insufficiency, which should be fully preoperatively. Prolonged neck extension in the prone position may lead to arterial occlusion. So alternative position should be considered. Problems with prosthetic joints. Nowadays, joint replacement is a very common entity, and patients, geriatric patients coming to you may be having prosthetic joint in place. So they have reduced range of movements. And while positioning, dislocation is quite likely. So we have to keep this in mind. What are the specific position issues in elderly? Coming to sitting position in geriatric age group, it is is mainly used in neurosurgery for exploration of the posterior fossa for good surgical exposure. They can have various problems because of sitting position itself, like postural hypotension, intractable cardiovascular instability, venous air embolism, and direct pressure damage. So, preoperative examination of the mobility of cervical spine and radiological review to determine the width of cervical canal should be performed and recorded in pediatric patients. While literature is being searched, there is no direct evidence of long-term difference or positivity in outcome from sitting position. So, worldwide, the sitting position is no longer used as commonly as it was in previous days. Coming to prone position in geriatric, I'm going to give more weightage in discussion of prone position because it's a position which gives maximum problems if not done properly. It's mainly used for spine surgery. There could be preoperatively severe damage to the spinal cord or nerves because of various reasons like age-dependent osteophytic bones, osteoporosis, protrusion of an intervertebral disc into the spinal canal, degenerative diseases or trauma, which is quite likely, tumor, epidural abscess, hematoma, arthritis origin, typically affects that lower cervical region. There are various physiological effects of prone. There could be decrease in cardiac output and blood pressure as a result of abdominal compression. There could be decrease in lung compliance, and it can be exaggerated, disastrous in elderly patients. So we need to focus on preoperative visit in ability to compensate for the physiological changes in the prone, magnitude of the surgical procedure, and associated stress response. You need to document by an independent specialist or neurologist patient's condition. Existing neurological deficit should be recorded for legal issues. Thorough examination to assess limitations to movements and flexion extension of the neck in case of vertebrobasilar compromise. Osteoporosis and cervical spondylosis. It could be there, could be asymptomatic, but close to critically compressing the nerve canals and cord. Obesity, which is very common nowadays in elderly patients, can create abdominal pressures once proning is given. So care must also be taken with the head and neck and to avoid pressure on the eye, as retinal artery thrombosis and blindness has been documented in literature. Pressure on the ears and nose and positioning of the neck, especially in elderly, is very vital. The shoulders, if extended, overextended beyond 90 degrees, they can cause brachial plexus injury. Stretch on the head of the humerus may compress on axillary neurovascular bundles. Pressure on ulnar nerve at the elbow can cause injury. So, coming to safety of prone position, turning the geriatric patient prone is a very critical maneuver as far as patient and anesthesiologist is concerned. So, special care should be taken to maintain the neck in a neutral position to secure spinal cord perfusion. Once in prone, the head can be turned to the side or can keep face down on a special soft border. Extreme caution should be taken to avoid positional and pressure damage to eyes, nose, breast, genitals, nerve, and muscle. Corneal abrasions and retinal ischemia from pressure is quite likely. Appropriate positioning support should be used to aid ventilation and maintain cardiac function. The chest should rest on rolls or special supports. The arm should be at the side in a comfortable position or extended with elbow flexed. The abdomen should be dependent and free of direct compression. Your hand should pass below the abdomen once patient is given prone. That's a very easy clinical tip. This is a position, the diagram of position with very carefully protected body. The dorsum of the foot, knees, pelvic area, breast, axilla, elbows, and face are all at risk of pressure necrosis in this position. So all these body parts should be properly supported and padded throughout the procedure. Coming to neurosurgical procedures in geriatric. Supine, prone, lateral, flexed, flex lateral, lithotomy, Trendelenburg, all need to be given in neurological surgery to aid the exposure. Preoperatively, assessment visit for specific position must be there for assessment of risk factors. For example, a patient with respiratory disorder may not tolerate steep Trendelenburg or a laparoscopic prostatectomy. Coming to lithotomy position in geriatrics, is commonly given for gynecological or urosurgical procedures. The physical injuries in lithotomy being injury to common peroneal nerve and saphenous nerve because of leg straps due to prolonged posture, obturator and femoral nerve damage as a result of excessive flexion of the thighs, and compartment syndrome of the lower limb if the procedure goes beyond stipulated time. The physiological disturbances are very significant in lithotomy in elderly patients. The functional residual capacity falls as a result of increased intra-abdominal pressure, resulting in hypoventilation, basal atelectasis, and hypoxia, which could be exaggerated in geriatric age group. The elevation of the leg increases venous return and may exacerbate heart failure. At the end of the procedure, lowering of the legs leads to venous pooling, reducing venous return and hypertension. If the patient is already bled, this hypovolemia as a result of intraoperative blood loss may be unmasked at this stage. Coming to trend landmark position in the supine position with operating table tilted head down to allow visceral to gravitate cephalite and giving better exposure to the pelvis. The physiological effect it causes is decreased cardiac output, heart rate, decrease in blood pressure, there is decreased lung capacities and ventilation perfusion ratio. There is increased risk of regurgitation in the elderly due to poor airway reflexes, and there could be intracranial venous congestion leading to rise in intracranial pressure. Coming to spine posture modification for surgery in geriatric. If the surgeries may not be for spine, but the position could be giving spinous stress, then what are the problems? There could be hyperextension of the lumbar spine to facilitate access to the pelvis. The lateral hyperextension of the spine to open up the renal angle and improve access to the kidneys. There could be flexion of the spine in the prone position to facilitate access for a PCNL. But all this position can exacerbate the physiological changes. There is potential to put a strain on the axial skeleton, and it can exacerbate any mechanical back pain this patient might be having preoperatively. Coming to difficult or contraindicated central neuractal blockade. We all know that regional anesthesia is the topmost priority for safety as far as geriatric patient is concerned. But it cannot be very easy always. Or I would say it is mostly difficult. So any elderly patient with pain or discomfort during positioning for neuractal blockade, it may cause perioperative compromise if you opt for general anesthesia or sedation. So what are the rescue we can have? First is peripheral nerve blocks for pain relief, especially in acute traumatic injury. Then the actual position can be easy. Then USG guided location in the compromised position, which is actually it's a boon for anesthesiologists. USG is a boon. Every anesthesiologist should learn this technique, which is now a common skill set of all of us. Then thirdly, paravertebral block may be placed under heavy sedation or general anesthesia without concerning for significant compromise or neurological injury. Now coming to the second part of my topic, that is orthotic concerns in geriatric patients. What is orthotics? The word itself is derived from the Greek word ortho, meaning straight, upright, or correct. Orthosis is an externally applied device used to influence the structural and functional characteristics of the neuromuscular and skeletal system. What are the functions of orthotics? It reduces speed, it prevents deformity, stabilizes the joint, it improves the function of a foot, it adjusts the posture and positioning. These are the diagrams or pictures of difficult orthotics which patient might be coming to you in the preoperative visit or emergency surgery intraoperatively. If the patient is having spinal collar and if it is into the place during surgery, of course it's a difficult area. If you are removing this perioperatively for the want of surgery, then care must be taken to protect the cervical spine. It's a very, very vital and is of prime importance. If patient is coming with lumbar orthosis or belt, which is a common occurrence nowadays, there are problems with patient positioning. There could be stiffness or pain because of lumbar belt, because muscles are not being used, and there is, I would say, pain because of loss of the posture or protective reflexes. There could be sores with long-term use. The regional block or neuraxial block could be difficult. If there are lower limb orthosis like calipers used, the tight calipers may cause common peroneal nerve palsy or foot drop, which can be attributed as a complication of neuraxial blockade. So this may raise medical legal issues post-operatively. So documentation is vital. Remember here, all spinal blocks, regional blocks, all elderly patients, thorough preoperative checkup and documentation. Lower limb orthosis can act like an exsanguinator. How? If removed after neuraxial blockade, vasodilatation can cause pooling of blood in lower limb, resulting in sudden hypotension, just like a Tourniquet effect or like cesarean patient after giving spinal anesthesia. So we have to be very careful here. Coming to hollow brace, it's used for a very serious injuries. So it's a rigid cervical spine. And of course, it's a difficult airway. So fiber optic bronchoscope or laryngoscope used for in awake condition is the rescue for securing the airway. Coming to MRI, you are called in MRI for elderly patient as a standby or monitor anesthesia care or giving anesthesia or sedation. So the main concern is about the metal. So previously the metal which was used in spinal support was stainless steel, but nowadays newer spinal supports have thermoplastic aluminum strip or stud, which is MRI compatible. But the problem is it may cause artifacts. So it has to be taken into consideration. And if required, we have to remove it. And then extra precautions to be taken as previously for the difficult positioning. What are the implications of long-term use of orthotics? There is difficult positioning because of restricted range of motion. There is loss of natural shock absorption and long-term joint damage. Could be spasticity, which is giving positioning, or muscle contractures, because the muscles are not being used in prolonged time. Risk of pressure sores because of loss of sensation and loss of sensory feedback and proprioception. The spinal orthotics must be put on and taken off within the guidelines of a spinal professional. Patients may be able to mobilize within set restrictions depending upon the severity of their injury. Failure to do this or non-adherence to guidelines may result in spinal cord injury, which is a very previous injury. These are my references. Thank you very much. I end my talk here. Thank you very much.
Thank you, Dr. Singde, for this nice deliberation. Excellent deliberation. I will discuss the questions at the end of the session. Okay. So we'd like to start the third talk, that is delayed recovery after general anesthesia. Yes. The speaker is Dr. Aparna Shukla. She is Associate Professor and Anesthesia and Critical Care, KGMU, Lucknow. She has 16 years teaching experience. She presented paper and was invited as guest faculty in many national conference, state conferences, worked as professor and head in the Integral Institute of Medical Sciences, Lucknow for 80 years. She is BCLS, CCLS trainer at KGMU, facilitated training of MO and CH of entire UP under National Health Mission. She has 18 publications, 9 international, 9 national, and PubMed index is 13. So I'd like to invite Dr. Shukla, please start your deliberation and come on the dais, please.
Hello, everyone. This is Dr. Aparna Shukla from King George's Medical University. Today, my topic is delayed recovery after general anesthesia. What is recovery? Recovery is a complex neurobiological process causing the patient's progression from unconscious state to wakefulness and restoration of consciousness. Delayed recovery is defined as inability to regain adequate level of consciousness, remaining the patient unresponsive or deeply sedated even 30 to 60 minutes after general anesthesia. Myth is that neural circuits that mediate induction are also responsible for recovery from, but the induction and recovery are not mirror image of each other. Recovery not only occurs due to cessation of action of general anesthetics, but it also involves more complex arousal mechanism. Induction is mediated by effect of general anesthetics on the various receptors like the GABA receptor, NMDA receptors, which causes the alteration at the corticocortical, cortico-subcortical, and thalamocortical connectivity. While recovery occurs both through the passive and the active process. In the passive process, there is cessation of action of general anesthetics, so their effect is reduced, and active process involve various arousal promoting brain centers. Various scales has been defined to assess the delayed recovery, though Glasgow Coma Scale was designed to assess the neurological status of the head injury patients, but it is also good scale to assess the post-operative recovery. Less than 8 shows slow awakening and unconsciousness, while for the fully awake conscious patient, the GCS score should be more than 12. L-rate scale is another good scale, which assesses the 6 parameters. Maximum total score is 10 and score of more than 9 is required for the discharge. I am not going into the detail of these scales. Now quickly revising the causes of delayed recovery from the anesthesia, which can range from the pharmacokinetic causes like the error in the dosing, prolonged duration of surgery, or prolonged infusion of the drugs, pharmacodynamic causes like the hypothermia, genetic variations. There may be metabolic and electrolyte derangement preoperatively or may occur any time during the perioperative period. Certain neurological causes or inappropriate ventilation may also be responsible for the delayed recovery from anesthesia. There are certain risk factors which can be assessed preoperatively, which can cause the delayed recovery, like patient's factor, extremes of the age, obesity, gender, cognitive dysfunction, hypoalbuminemia, comorbid conditions related to liver, kidney, lung, chronic drug therapy, and drug factors like the dose, time of administration, like if the neuromuscular blocking agent, opioids, benzodiazepine are given towards the end of the surgery, it automatically causes the delayed recovery. Old age causes the increased sensitivity towards the general anesthetics, opioid, and the benzodiazepine. There is decline in the function of the central nervous system in the old age, decrease in the volume of distribution, clearance rate, and decreased plasma protein binding. MAC value is also decreased with the advancing age. And these all factors, along with the deranged hepatic and renal functions, are the causes of delayed emergence in the old age. Infants are more sensitive to effect of general anesthetic because of the immature liver and immature renal functions. Initially, the increased dose of the drug is required because of the reduced plasma protein binding and increased volume of distribution. Larger amount of the drug is available at plasma. So recovery is delayed in the infant. They are also more prone to hypothermia as well as the hypoglycemia. Gender also affects the recovery, as it has been demonstrated that males are more sensitive and females are less sensitive to the hypnotic effect of anesthetic agents, especially the propofol. However, the females are more sensitive to the neuromuscular blocking drugs. Obesity is the major risk factor for the delayed recovery. If the drug is not given on the basis of lean body mass, then the excess of the drug deposits in and later on it is released in the plasma and causes the delayed recovery from the anesthesia. Pharmacokinetic causes, obesity we have already discussed. In the liver disease and hypothyroidism, the metabolism is deranged. Renal disease affects the elimination of the drug. Certain drugs like when benzodiazepine and L-fentanyl are given simultaneously, both are metabolized by the cytochrome P450, or when benzodiazepine is given with the propofol, both act on the GABA receptor. In these cases, the effect is prolonged. New agent, as we all know, interacts with the aminoglycoside, calcium channel blocker, diuretics. Congestive cardiac failure reduces the blood flow to the various organs and prolongs the somnolence. Parkinsonism, Down syndrome, and other cognitive dysfunctions are also responsible for the delayed metabolism of the drug and recovery. Hypothermia, as we all know, prolongs metabolism and elimination of the drug. It has been studies that for each 1 degree increase in the body temperature, MAC decreases from 5 to 7%. It also causes of activity of the central nervous system. With hypoalbuminemia, protein binding is reduced and free drug in the plasma is increased. Continuous infusion of the drug or prolonged duration of the surgery also increases the volume amount of plasma, and therefore the recovery is delayed. Alveolar hypoventilation prolongs the time taken to exhale the volatile agent. OPI reduces the sensitivity of the brain stem to the carbon dioxide. Very common cause is the residual neuromuscular blockade, which is seen with the large doses of neuromuscular blocking agent given, or if it is given at the end of the surgery or extremes of the age, hypothermia, aminoglycosides and other drugs. These all factor potentiate the neuromuscular blocking drugs. If patient is taking chronic pharmacotherapy like with benzodiazepine, barbiturates, antipsychotics, antidepressant, anticholinergic, and even some so-called benign herbal medications may interact with the anesthetic agents intraoperatively and are the reason for delayed recovery of the patients. Metabolic derangement, especially the blood sugar level, is very important. Patient's blood sugar status should be maintained perioperatively, as hypoglycemia and hyperglycemia by one way or the other cause the CNS depression and the delayed recovery. Similarly, hypotension, potassium, calcium level, and hypermagnesemia, which is commonly seen in the eclampsia and preeclampsia, all these drugs cause the CNS depression. Respiratory causes may be due to central cause, dysfunction of neuromuscular imbalance, or perioperatively it may be iatrogenic due to inappropriate ventilatory techniques. And it may lead to hypoxia, which causes the depression of central nervous system, or hypercapnia, carbon dioxide narcosis occurs. Hypocapnia causes the cerebral vasoconstriction and reduced blood flow to the brain. It is also a cause of delayed recovery. Genetic and the other causes may be abnormal or absent plasma pseudocholinesterase, plasma cholinesterase enzyme, repeated or large doses of the succinylcholine when more than 6 to 8 milligram per kilogram is given. Patients with myasthenia gravis, muscular dystrophy are very sensitive to the effect of neuromuscular blocking drug. Genetic modification of enzymes that metabolizes the propofol or opioids is also described in the literature. Certain surgeries are very prone for the stroke, ischemia, and hemorrhage, like neurosurgery, cardiopulmonary bypass. In the robotic prostatectomy, steep Trendelenburg position causes the cerebral edema, which is usually unrecognized in the intraoperative period, and it is recognized postoperatively that when patient is not awakening from the general anesthesia. Apart from the neurological causes, valproate toxicity, Hunter syndrome, and myxedema coma are also less common causes of the delayed recovery from anesthesia. Now, what should we do when delayed recovery is suspected, when patient is not awakening even after 30 minutes of stopping all the anesthetic agent? First of all, we should check all the anesthetic agents, like we should check the vaporizers, gas source, workstation, if some vaporizer is on accidentally, or if the nitrous oxide is going into the patient's system by accident, or there may be intravenous agents going through the IV tubing. So change of the IV tubing, flush the breathing circuit, check the ABC of the patient, airway, breathing and circulation, and at the same time give sample for the ABG analysis. Review the history and investigations. If patient is having any comorbidity, any problem in the investigations, in the preoperative period, drug doses and timing must be checked. Other perioperative events like hypoxia or hypotension for which management was done should be checked. Facilitate the remnant of anesthetics and warming of the patient. 100% oxygen is given for 10 to 15 minutes for the volatile anesthetic. So hyperventilation is done for the short period of time, but hypocapnia is avoided. Forced diuresis is done. Patient should be warmed with a warm blanket. Forced air warming. OT temperature should be increased. Warm fluid should be given. Metabolic abnormality must be corrected. Correct the blood sugar level, correct the sodium level, and other electrolyte abnormalities must be corrected. 1 shot of neostigmine can be given. If large doses of benzodiazepine has been given, flumazenil can be given by in the doses of 0.2 milligram IV up to 1 milligram. Opioid, for the opioid toxicity, naloxone is good, 0.04 milligram IV up to 2 milligram. For vecuronium or rocuronium, Sugmadex can be given 4 milligram per kilogram. 16 milligram per kilogram can be given for the rocuronium, but not for the vecuronium. Has not been studied. EEG, this monitoring, neurological opinion should be sorted, and patient should be shifted to ICU. Frequent neurological examination is must. Maintain the ABC of the patient, consider any CNS effect or any prolonged hypoxia perioperatively. If patient is not recovered in 6 to 8 hours, then CT should be done to rule out any neurological event. Certain new drugs has been developed like methylphenidate, caffeine, dextroamphetamine, physostigmine, nicotine. These drugs are under trial and are coming with the promising results. So maybe our future is not as bad as present. These are the few RCTs which shows the use of caffeine, dextroamphetamine and nicotine is coming with the good results. So the take-home message is that recovery from anesthesia involves multi-factors. It is multifactorial and may not always be due to anesthetic agent. All factors must be considered. When all other causes has been excluded, intraoperative neurological event must be expected, which is not very uncommon. Maintain the airway, breathing and circulation during recovery so that further damage is not done iatrogenically. Timely and systematic approach is the key to success. Last but not the least, there is no alternative to good and vigilant intraoperative care. It means that all the patient factor must be considered while choosing anesthesia for the patient, while choosing drug for the patient. Perioperative, preoperative morbidity must be considered, and if the patient is taking any drugs which can alter the effect of anesthetic agents intraoperatively. Patient's body weight, patient's age must be taken into account while planning for the anesthesia for a patient. Thank you very much. Good wishes from King George's Medical University, Lucknow. Thanks for patient listening.
Thank you for this excellent talk. Now, all the topics are now open for discussion. There is no question in the chat box. Audience, do you have any question? Can you ask? Do you have any question to any of the speaker? Yes, please. Yes, please. So there is no question in the chat box also. So I think all the doubts are cleared very nicely by the speakers. Yes.
Unmute yourself, Dr. Surekha.
Hello.
Yes, ma'am. Unmute yourself, ma'am.
Am I audible?
Yes, yes.
This is regarding my talk on orthotic and positional issues. One thing I just forgot to mention, in the flow of discussion regarding geriatric patients and positioning. One more important thing which stops us from giving ideal position is patients' mental status. Many times they have many cognitive dysfunction, understanding problems, and they're uncooperative. In that matters, we have to be extra cautious to give some pain relief. We have to give them counseling, especially for an adequate pain relief, so that they can be very cooperative during position also. And many times before giving general anesthesia, I think pain relief block with USG guided technique, and then going for proper GA can be a very advantageous in long way. That will reduce the amount of general anesthesia required, lesser relaxation, and of course then post-operative recovery will be better. Thank you very much. I just wanted to stress this point.
I have one question to Dr. Singh.
Yes,
ma'am. How do you position a patient suffering from Alzheimer's disease? It's a very, very difficult situation.
Yes, ma'am.
How to tackle this? Or
Actually,
how we tackle this patient?
Yes, madam. Actually, nowadays patient coming to geriatric surgery, they are quite old, more than 90 only. So in these patients, we have to be very much in relation with the patient accompanying person. So we have to know how much the grade of Alzheimer's is. And in those cases, I think thorough checkup and general anesthesia, I think is ideal. Because patients may not tolerate that very well if it is in the constraint of giving the safe general anesthesia. Otherwise, we have to give light sedation and just knock their little sensations off. But it's a very difficult question, I think.
Yes.
And it is a patient-tailored problem. So depending upon the patient's condition, surgery, and how much risk you and your surgeon are ready to take, we have to be in a very compromised state regarding this.
Does any drug help the patient is taking for Alzheimer's?
Actually, madam, not exactly in Alzheimer's, but for cognitive dysfunction, sometimes, many times, haloperidol and in a very small dose, they are mentioned in literature.
Okay, thank you.
Thank you.
Thank you. So there is no question in the chat box. So the organizers, do we conclude the session?
Thank you so much, ma'am.
Yes. So the organizers, do we conclude? Thank you all the speakers for this excellent session.
All the sessions were very nice, ma'am. It was nicely elaborated in and touched all the topics of pediatric anesthesia. It was very nice. Chavan ma'am, Sinde ma'am, and Shukla ma'am. All the topics were very good.
Thank you, ma'am, for the very informative session. And geriatric is a very important and very sensitive age group. So we should be, as an anesthetist, we should be knowing each system, because each and every system is involved in this type of patient. And it becomes very difficult for us to assess everything. And it is our responsibility to have a proper pre-operative evaluation, because these patients are on multiple drugs involving multiple systems. So it becomes a very challenging task for us to give anesthesia to such kind of patient. Thank you, ma'am. It was such an informative and a very nice session. Thank you, ma'am.
Thank you so much for giving us the opportunity. Thank you very much. Thank you, Bhattacharya madam. Hope you remember me, ma'am.
Yes, of course.
Ma'am, sorry to disturb you again. I have one question from Dr. Aparna. Hello? Hello?
Aparna hasn't joined.
Yes. Is there?
She's not here.
Yes, Dr. Alpana left, I think.
Okay, ma'am. No problem. No problem.
Shall we conclude, ma'am?
Yes. There is no question in chat box. All the doubts are
No,
cleared
ma'am. There is
by
no
nicely
question.
by the speakers. So we can conclude here.
Thank you, Bhattacharya madam and organizers ISACON 68.
Thank you, ma'am.
Thank you.
So the next session will of e-paper presentations will start at 2 p.m. Thank you. So good afternoon all. Now the next session is e-paper presentations. Our chairpersons are Dr. Amit Kohli and Dr. Bindu. And our first presenter is Dr. Ramyashri S.
My paper topic is to compare the efficacy of intrathecal 0.5% hyperbaric bupropion 5 mg with fentanyl 10 microgram versus 0.5% hyperbaric bupropion 5 mg with fentanyl 20 microgram on quality of anesthesia and hemodynamic parameters in preeclamptic parturients undergoing cesarean section. Randomized study. Introduction. Preeclampsia is a multisystem disorder of unknown etiology characterized by development of hypertension to the extent of 140 by 90 mmHg or more with proteinuria after 20th week of pregnancy in a previously normotensive woman. GA is often considered unsafe because of a potentially difficult airway due to airway edema, hypertensive response to laryngoscopy, risk of aspiration pneumonitis, use of magnesium sulfate, leading to delayed recovery. Neuraxial blockade has become increasingly popular as it offers rapid onset of anesthesia and takes less time to perform. However, spinal anesthesia, particularly in parturients, is associated with hypotension attributed to decreased different sympathetic outflow, and because uterine perfusion is reduced in preeclampsia, it is important to reduce the hypotension in these patients. To achieve this goal, lower doses of intrathecal opioids can be used to reduce the incidence of maternal hypotension and vasopressor requirement while producing adequate surgical block. Aims and objective to compare the efficacy and safety of intrathecal low-dose bupropion with fentanyl in terms of hemodynamic parameters and time of onset and duration of sensory and motor blockade. The study is a prospective randomized double-blinded one conducted over 2 years. Parturients undergoing elective LSCS under spinal anesthesia and fulfilling the inclusion criteria were enrolled. All patients were kept fasting for 8 hours. Injection ranitidine and metoclopramide were given half an hour prior to surgery. On arrival to operating room, patients were preloaded with 10 ml per kg of RL. The baseline systolic blood pressure, diastolic blood pressure, heart rate, and oxygen saturation were recorded. Under strict aseptic precautions, subarachnoid block was performed. Sensory testing was assessed by loss of pneumatic sensation to 23 gauge sterile hypodermic needle. Motor block was assessed using modified Bromide scale. Hemodynamic values were recorded every minute for the first 5 minutes, at 5 minutes for the next half an hour, and at 10 minutes for the next 120 minutes. Hypertension was considered as a 20% fall in systolic blood pressure from baseline was treated with IV fluid and IV ephedrine. Bradycardia was considered as a 20% fall in heart rate from baseline was treated with IV atropine 0.6 mg. Rescue analgesia was given with slow IV injection of fentanyl 50 microgram, and rescue drug in nausea and vomiting was IV injection of ondansetron 4 mg. A total of 100 participants were divided into 2 groups, BF1 and BF2. Table 1 summarizes that both these groups were similar with respect to age, weight, and height distribution and duration of the surgery. The percentage decrease in MAP from baseline is 12.1 plus or minus 2.3% in group BF1 and 13 plus or minus 2.1% in group BF2. Table 2 shows that there was statistically significant groups in the time taken to reach maximum block, time taken for 2-segment regression, and recovery time from sensory block. Table 3 shows that there was statistically significant difference between the 2 groups in the time taken for onset of motor block, time taken to reach the maximum motor block, and the recovery time from motor block. In this study, we found that by reducing the dose of intrathecal bupropion by adding fentanyl, the fall in blood pressure following subarachnoid block was less than 20% from baseline. The time for onset of sensory block and time to reach T10 level was comparable between the 2 groups. There was a positive correlation that the increase in dose of intrathecal fentanyl increases the duration of postoperative analgesia. There was early motor recovery from spinal anesthesia leading to early discharge from the post-anesthetic care unit. In conclusion, by reducing the dose of intrathecal bupropion and adding fentanyl leads to better hemodynamic stability, lesser requirement of vasopressor, reduced intraoperative and postoperative nausea, vomiting, and a prolonged postoperative analgesia. These are my references. Thank you.
Dr. Ramya Shri. Am I audible? Hello, am I audible, Dr. Ramya Shri?
Yes, yes, yes.
Could you please tell the time taken for onset of the motor blockade when you added
I
fentanyl?
think, sir, ma'am, she left, I guess. She just exit.
Oh, okay.
Just hold on.
Okay, then.
She's there. Just 1 second. Dr. Rameshri, please accept the request for being panelist. Thank you.
Hello.
She's here, ma'am.
Hello, Dr. Ramya Shri. It was a
Hello,
nice presentation. Could you please tell me the duration, the time taken for the initial onset of motor blockade when you added fentanyl?
Ma'am, it was 7 minutes in one group in which we added 10 microgram, and it was 9 minutes in the other group in which we added 12 micrograms, 20 micrograms fentanyl.
7 minutes and 9 minutes.
Yes, ma'am.
Okay. And the total duration of motor blockade?
Ma'am, it was almost 3 to 4 hours, ma'am. In one group, it was 120 minutes. In the other group, it was much prolonged, ma'am. Where we added 20 micrograms of fentanyl.
You have not taken the control group in the study, no, with plain bupivacaine to compare?
No, ma'am. Control group was not taken, ma'am. We added, we compared only the 10 and 20 micrograms of fentanyl, ma'am.
Okay, okay, fine. Okay, thank you.
Thank you, ma'am.
Our next presenter is Dr. Adiba Shabnam.
Good morning, everyone. This is Dr. Adiba Shabnam. I'm here to present my paper, which is comparative study of effect of ileal tracheostomy and prolonged intubation patients requiring long-term mechanical ventilation. Advances and improvements in healthcare nowadays have increased the need of prolonged ventilatory support among critical illnesses in ICU. Airway access for mechanical ventilation can be provided either by an endotracheal tube or a tracheostomy tube. Most patients with respiratory failure are ventilated through an endotracheal tube generally, but changing this to tracheostomy tube is often considered when there is a prolonged ventilation requirement. Hence, here is an attempt by me to assess if early tracheostomy overweighs the risk of prolonged endotracheal intubation. Of my study are to compare the effects of early tracheostomy versus prolonged intubation in ICU in patients who require long-term mechanical ventilation in terms of duration of ventilatory support, length of ICU stay, and incidence of ventilator-associated pneumonia. I have selected 60 patients admitted into ICU who are of age 15 to 55 years, and the informed written consent was taken from the patient attenders. And the two groups were made ensure that they're similar in mean age-sex ratio diagnosis at the time of ICU admission. These patients were divided into tracheostomy group and the intubation group. Tracheostomy group patients, surgically tracheostomy was done from day 3 to day. And intubation group, the patients were intubated throughout their hospital stay until extubation or death. Age-wise, the two groups were ensured that the mean age was around 30 years in both the groups, and sex-wise, both the groups were ensured that 70% of constituted by males and 30% is by females. Duration of mechanical ventilation was observed to be 11.9 days in intubation group and 9.3 days in tracheostomy group. Statistically significant difference was observed. Whereas the length of ICU stay days in tracheostomy group was 11.3 days, which was also statistically significant. The intubation group mean duration of mechanical ventilation after ventilator-associated pneumonia was 7.2 days, whereas in tracheostomy group it was 4.9 days. Statistically low significance was we observed. As the results, I would like to say that there is a decrease in mean duration of mechanical ventilation in tracheostomy group, and the length of ICU stay was less in tracheostomy group. However, incidence of WAP was statistically insignificant in both the groups, but the duration of mechanical ventilation after WAP was around 5 days in tracheostomy group and 7 days in intubation group, with the lower statistical significance. Tracheostomy is one of the oldest performed procedures frequently performed in ICU. It is a surgical procedure in which the anterior aspect of the neck we create an incision, and via that stroma we try to put a tracheostomy tube. In acute settings, it is generally indicated for severe facial trauma, angioedema, tumors of head and the neck. Whereas in long-term chronic settings, we do it in patients requiring long-term mechanical ventilation. It is recommended because it also provides better respiratory mechanics, nutrition, patient comfort, etc. Laryngeotracheal injuries constitute an important element for specifying the optimal moment for performing tracheostomy. However, that optimal moment is controversial. It depends on the clinical situation and individual preference. I would like to say that tracheostomy has helped us to increase the patient mobility, more secure airway, increase the patient comfort, improve airway suctioning, less direct endolaryngeal injury, better oral nutrition, enhance phonation communication, decrease chances of nosocomial pneumonia in patient subgroups. I would like to conclude that early tracheostomy has led us to decrease duration of mechanical ventilation and decrease the length of ICU stay, decrease the duration of mechanical ventilation after ventilator-associated pneumonia. Thank you.
Hello. Hello, doctor.
Dr. Bindu. Dr. Shabnam hasn't joined yet. Ma'am, unmute yourself, please.
We'll proceed to the next presenter, sir.
Okay, ma'am. Okay, ma'am. So the next presentation is Devyani Solanki.
Hello everyone, I am presenting a paper of comparative evaluation of intermediate versus propofol on hemodynamic response following endotracheal intubation in adult patients. The increasing importance of the safe anesthesia practice has attenuated the need for with smooth induction and intubation, stable intraoperative hemodynamic and rapid recovery with minimal adverse effect. The fluctuation in heart rate and blood pressure, though brief and well tolerated by healthy individuals, may be deleterious in patients with cardiovascular compromise. Choice of induction agent hence maintain a safe range of hemodynamic parameters, heart rate, systolic blood pressure, and diastolic blood pressure. Recent study was carried out to compare and evaluate the efficacy of propofol and idomidate in preventing hemodynamic response after laryngoscopy and endotracheal intubation in reference to change in heart rate and change in blood pressure. Total 60 patients 1 and 2 of either sex and age between the 18 to 16 years posted for elective surgery were included and randomly divided into two groups. Group P includes injection propofol 2 mg per kg IV, and the group E N is equal to 30, where injection idomidate 0.3 mg per kg IV given. A detailed pre-anesthetic evaluation of all patients were done. The effect of the IV induction agents were observed in relation to hemodynamic changes like heart rate, systolic blood pressure, diastolic blood pressure. After induction, after intubation at 1 minute, 3 minutes, 5 minutes, 10 minutes, 15 minutes of the intubation. The observation of this study were compared with the observation of the other study and between the two groups. Exclusion criteria are those taking the antihypertensive medications, patient with the cardiac, renal, hepatic, and the cerebral diseases, obese, pregnant, and the nursing woman, patient with anticipated difficult intubation, patient with history of suggestive sensitivity to drug used in the study, and the patient not willing to consent. All the continuous variables were recorded as a mean plus minus SD. The data obtained from each group were analyzed statistically by unpaid t-test using GraphPid software. 0.05 was considered significant. Result shows demographic data are not significant with each other. Table 2 shows the changes in the heart rate where increase in heart rate after intubation in both the group, but difference was statistically not significant. Table 3 shows changes in the systolic BP where statistically significant decrease in the systolic BP in group P as compared to group E after induction and intubation. Table 4 shows that after induction and intubation, there was a decrease in the systolic BP in group P as compared to group E, which was statistically significant. Hemodynamic responses, where after induction there was a decrease in heart rate in both the group, but there was no significant difference between the two groups. This fall in heart rate could be attributed to the anxiolytic action of fentanyl, which was used for pre-medication. Around 10 minutes and after intubation, blood pressure was become normal as compared to pre-induction in group P, whereas in group E, blood pressure remains stable after induction, which shows that etomidate do not have effect on baroreceptor-mediated pressure response. Thus, etomidate provided better hemodynamic stability during induction and intubation. Propofol and etomidate reduces rise in while etomidate shows lesser hypertensive effect. Incidence of pain on injection and bradycardia was significantly higher in group P. Conclusion is single induction dose of propofol etomidate attenuates the hemodynamic response in laryngoscopy and intubation. However, propofol caused significant hypotension while etomidate provided more stable hemodynamic conditions. If there were be no contraindication, it would be preferred over the propofol for general anesthesia, particularly in hemodynamic unstable patients. Thank you.
Thank you. You have conducted a study comparing two induction agents, propofol versus etomidate. Can you please figure out one thing, that what is? अच्छा, इसने join नहीं किया. चलो फिर next पे चलते हैं. On to the next presentation.
Next presentation is of Dr. Abhishek Zala.
Good morning, everyone. I am presenting a pre-paper and the title is Evaluation of Addition of Etomidate to 1% 2-chlorprocaine in spinal anesthesia for short duration surgeries. Conventional spinal anesthesia is one of the most common anesthetic procedure for infra-umbilical surgeries. 1% 2-chlorprocaine is a good choice for shorter duration of surgeries. Duration of 1% 2-chlorprocaine is 40 minutes. Post-operative pain is undesirable. So adjuvants like this, dexmedetomidine used with it in subarachnoid block will provide effective analgesia post-operative. Dexmedetomidine, when used in dose up to 10 microgram intrathecally, it will cause faster onset of sensory and motor block and provide longer duration of analgesia in post-operative period without causing significant hemodynamic. For opioids as an adjuvant in spinal anesthesia are used frequently, but side effects of opioid like urinary retention can be avoided by using dexmedetomidine. My primary objective is first rescue analgesia and need post-operatively. And secondary objective is sensory blockade. Onset of sensory block at L1 dermatomal level, time to achieve maximum sensory level, time for 2-segment regression. In motor blockage, onset of motor blockage, time to achieve maximum motor blockage and duration of motor blockage. Duration of effective analgesia, to observe any changes in hemodynamic parameters, to observe any complications. The material and method, type of study is prospective randomized double-blind clinical study. Sample size estimation was done using first post-operative analgesic requirement parameter with confidential interval is 95% and power of study is 80%. Effective sample size is 30 in each group. These are my inclusion and exclusion criteria. Grouping and randomization done and 2 groups of patients each using will receive injection plain 2% 1% 2-chlorprocaine 40 milligram and group C plus D study group injection 2-chlorprocaine plus injection dexmedetomidine 10 microgram. Ethical clearance we have obtained from ethical committee for human research and my CTR and registration number is this. Pre-anesthetic evaluation of the patient was done and thorough counseling regarding the procedure and the purpose of study was done. Basic necessities like anesthetic machine monitor, resuscitation drug, airway equipment and suction apparatus was kept. A sterile spinal tray was kept ready. All baseline parameters like ECG, heart rate, NIBP and SpO2 and respiratory rate were observed. We pre-medicated the patient with injection glycopyrrolate and ondansetron. No sedative pre-medication will be given. Drug preparation as mentioned before For ensuring blinding, randomization was done using seal envelope method, which were numbered and were opened by the designated consultant of the work area just before the administration of anesthesia. Drug was prepared using sterile technique according to group allocated and was then handed over to the attending anesthesiologist who was unaware about the study. Myself, as an observer, was not present while suboperative drug was administered. After the induction, I was called inside the operating room. Under all aseptic and antiseptic precautions, final anesthesia was performed, and surgery was allowed once the sensory and motor blockage were achieved. Assessment of spinal blockade, like sensory block, assessment was done with tip of 24 gauge needle. Onset of sensory block is defined as time interval from complete subarachnoid drug injection to onset of complete loss of pinprick sensation at L1 level. Time to reach highest sensory level will noted. Assessment of motor blockade assessment was started immediately with time of intrathecal injection taken as 0 minutes. Onset of motor blockade, time to achieve maximum motor blockade and duration of motor blockade. Assessment of analgesia, duration of effective analgesia, requirement of first post-operative analgesia. Intraoperative monitoring will be done. And statistical analysis is software used was faster in group chlorprocalciferous dexmedetomidine compared to control group. Duration of motor blockage is also total duration of motor blockage was longer in group chlorprocalciferous dexmedetomidine compared to control group. There is no significant statistically significant changes in hemodynamic parameters like systolic blood pressure, diastolic blood pressure, and pulse rate. And first rescue analgesia needed. There was longer duration of analgesia in study group than in control group. So our discussion is post-operative duration of surgeries. 1% to chlorprocaine local anesthetic is a good choice, and when it is added with adjuvant like dexmedetomidine, local duration of analgesia can be provided post-operative. Dexmedetomidine, when used in 10 microgram of dose, intrathecally it will provide faster onset of blockade and effective analgesia post-operatively without causing any significant bradycardia and hypotension. Dexmedetomidine in a dose of 10 microgram is a good choice for adjuvants in subarachnoid block. Then opioids like fentanyl, because of side effect of opioid like urinary retention, pruritus, nausea, and vomiting. So our conclusion is addition of dexmedetomidine with 1% to chlorprocaine in subarachnoid block will provide faster onset and prolonged duration of sensory and motor blockade. No significant incidence of hypotension, bradycardia, better post-operative analgesia. These are my references, and thank you.
Thank you, Vipini. Hello, next.
Next presenter is Dr. Snehal Thombre.
Hello everyone, myself Dr. Snehal Thombre from IMS in Some Hospital, Bhubaneswar. Today I am going to present on effect of dexmedetomidine infusion on extubation. Is it an asset or liability? Though dexmedetomidine has shown to improve all parameters at extubation, level of sedation might be a hindrance for removing the endotracheal tube, which leads to prolongation of extubation time. Due to known property of cooperative sedation, sedation of patients after dexmedetomidine infusion was not studied adequately. There are several studies concluding the beneficial effects of dexmed on extubation quality and hemodynamic stability. But there is no mention about time of extubation for attempting reversal, and also no adequate documentation on sedation scores and PSU discharge time after dexmed infusion for more than 2 hours in general anesthesia. Our study was conducted to evaluate primarily the effect of dexmed infusion on extubation time and post-operative sedation score. Secondly, a hemodynamic response to extubation and PSU discharge score was observed. Materials and method. This is a prospective comparative study with randomization using computer-generated random numbers. The study has followed Institutional Ethics Committee guidelines. It was conducted at IMS in Some Hospital, Bhubaneswar, Odisha. It is a CTRA registered trial. We included patients between 18 to 60 years of either sex who were ASA grade 1, posted for oncosurgeries more than or equal to 2 hours of duration. We excluded the patient who refused for participation and also who were allergic to drug. Relaxation was given within 30 minutes of end of surgery. Out of all the patients observed, 65 patients were randomized, including group A 33 and group B 32 patients. Methodology proper. After screening for eligibility, a written informed consent was taken from all the patients and blinding was done with opaque envelope technique. After checking for NPO status and securing IV line, standard general anesthesia has been given. And infusion of dexmed was started with loading dose of 1 mic per kg for 10 minutes, followed by maintenance of 0.6 mics per kg. And in group A, after stopping in dexmed infusion, reversal was attempted and extubation was done. While in group B, reversal was attempted 10 minutes after stopping dexmed infusion. Results, if we compare demographically, both the groups were comparable. While comparing the two groups for variance at baseline and at we can see there was no significant difference. While at extubation, there was no significant difference, but the standard deviation for group B was more as compared to group A. While comparing for extubation time, the extubation time was less for group B, and similarly for Ramsey's sedation score at the time of extubation and at 15 minutes, we can see that group B patients showed better scores as compared to group A. When we saw modified ultra score at 30 minutes post extubation, we can see 66% of group A patients were discharged at the end of 30 minutes as compared to 90% of patients which were discharged in group B, showing that group B patients has early recovery as compared to group A patients. When dexmed infusion is used for balance anesthesia for patients undergoing long periods of general anesthesia, the more time is needed for psychomotor cognitive recovery of the patient, which may affect the discharge criteria of PSU. In a study, they have by Bakhabindu, they have studied dexmed with 0.75 mics per kg 15 minutes before extubation, which showed hemodynamic stability and smooth extubation, while there was increased incidence of bradycardia and hypertension with this dose. So in our study, we have used 0.6 mics per kg. In another study, they have studied the context sensitivity half-life, according to which in our study, we took 10 minutes since the context sensitivity half-life of dexmed is 8 to 10 minutes after more than 2 hours of infusion, where we wanted benefit of hemodynamic sedation and post-extubation. So we conclude that stopping dexmed infusion 10 minutes before attempting reversal from anesthesia has reduced the extubation time and significantly improved post-operative sedation scores than to continue it. And the percentage of patients discharged from post-anesthesia care unit at the end of 30 minutes was significantly more in patients where stopped dexmed infusion 10 minutes before attempting reversal. These study results will expedite the recovery and shorten the PSU stay. These are my references. Thank you.
Yeah, thank you.
Good afternoon,
Nice
sir.
presentation. Good slides, Nehal.
Yes.
Right, that is there. I'm very happy. And those postgraduates who are listening us today, kind of a thing that there should be less material on the slides. I keep on emphasizing on this particular session. So neatly done. I have 1 or 2 things for you, Snehal. Right. Do you think that dexmedetomidine we all are using, right, for intraoperative this thing as well? So is it FDA approved for the purpose for which you have studied?
Yes, sir. In 1999, it was approved, FDA approved for IV use. And there was a study in which I will just mention the name.
Yeah, no problem.
Yeah, Juhi Park et al. Yeah, Juhi Park et al. They have studied in ICU patients where they have mentioned about the use of dexmed. We can use up to 8 hours of a continuous
Cut it short.
infusion.
Cut it short. Yes, we all are using dexmedetomidine for multiple purposes. But yes, for FDA has just even till date approved dexmedetomidine only as an intravenous agent for ICU sedation.
Yes.
That is the only intravenous indication which was approved by FDA till date. Right, that is there. The rest approvals are pending, though we are using it in almost all the routes as well as in almost all the purposes. But for all academic reasons, I just wanted to tell you this fact that it is only for the ICU sedation. It is done. Thank you.
Okay, sir. Thank you, sir.
Bindu, any question you want to ask?
No, sir. Can proceed for the next session.
Next
presentation.
I think we are done for the day.
It was the last slide, last presentation of the day.
Okay, fine, sir. Thank you.
Yeah, thank you.
I think we can conclude.
Yeah, we can conclude the session. Best of luck, everybody who joined us today for the future academic sessions. And I hope next time you guys will be seen in some of the competitive exam session, right? That is there. So keep working hard and best of luck.
Thank you all those who have presented, and thanks for the opportunity. I wish all the best to one and all. Thank you so much.
Thank you, everyone.